Hi everybody, I'm Dr. Rena Chawla, Faculty of Obg3 at Cerebellum Academy, and now we start with the gynae rapid revision. So we finished the obstetrics part of it. In gynae, we start first of all because you should know a bit of basic physiology of menstruation. We won't go into too much detail, just what is required to know for the exam. Okay, as a quick revision. Now, when we talk about physiology of menstruation, always remember this chart. This chart is very, very important. What does this chart show? The top part shows the ovulation, the ovulatory part of the cycle or the ovarian part of the cycle, right? These two graphs are also equally important. These show the hormonal changes during the ovulatory cycle, and then along with this, in the next slide, I'll show you the uterine cycle. So everything goes simultaneously. What happens when the woman is just got her period on day 1 or day 2? You can see the hormones here, they're all at baseline. Okay, this is the LH and FSH. LH is blue. Okay, FSH is green, estrogen is orange, and progesterone is purple. So all of these you can see on day 1, day 2 are baseline. What happens is that there's a set of follicles which start getting recruited, and this recruitment starts in the previous cycle. Out of this, one follicle will then start majorly growing. Okay, it's first a primary follicle, then it becomes a secondary follicle. Okay, with an antrum. So this is called a Graafian follicle, the one over here. Okay, and this Graafian follicle is going to secrete estrogen. So that's why you can see the estrogen is rising here. Now, estrogen and progesterone have a negative feedback on FSH and LH. If you remember the HPO axis, estrogen, progesterone will have a negative feedback on FSH and LH. But there comes a point when the estrogen becomes very, very high. When the Graafian follicle is mature, it's secreting maximum amount of estrogen. At this point of time, here, when the estrogen is very, very high, what's going to happen? This sudden rise in estrogen, instead of a negative feedback, gives a positive feedback on LH. Also FSH, but more so we're stressing on LH. So a sudden rise in estrogen, when estrogen levels are very high, they cause, instead of a negative feedback, they cause a positive feedback. That means LH is going to rise. And this rise in LH is what is going to trigger ovulation. So questions have come from this graph. Write the hormone as X, and you have to identify X. Or they will say which hormone or what precedes ovulation. What precedes ovulation is the LH surge. This rise in LH is called the LH surge. And what precedes the LH surge is the rise in estradiol. Okay, remember the main hormone in the reproductive woman is estradiol. Estrogen comes in three forms: estrone, estradiol, and estriol. Okay, estrone is the least active form. It's what you find in postmenopausal women. Estradiol is the one in the reproductive age group, and estriol is what you find in pregnancy. Okay, so what's happened now? Ovulation has happened because of the LH surge. Now, once ovulation has happened, what happens to this remaining Graafian follicle? It forms what is called the corpus luteum. And this corpus luteum now starts secreting this purple hormone, that is progesterone, which peaks at day 21. So how do we know ovulation is happening? One of the best tests that tells us is a very high level of progesterone on day 21. A value more than 10 nanograms per milliliter will tell us definitely for sure that ovulation has happened at the correct time. Okay, now what else is happening? So once the progesterone rises and corpus luteum grows, there comes a time when pregnancy, the uterus and the ovary realize that pregnancy is not happened. Now, if pregnancy has not happened, this corpus luteum is going to degenerate and form a corpus albicans. And that leads to a drop in both the estrogen and progesterone levels, and everything comes gradually back to baseline when the period happens. So this is what's happening in the ovulatory cycle. And simultaneously, along with this, what we are seeing is this cycle. What is this cycle? This is the endometrial cycle. So the endometrial cycle is going on alongside, and you can see this is menses. During menses, the endometrium has broken down, and then it starts getting proliferated again under the influence of estrogen. So estrogen is going to cause proliferation of the endometrium, and once ovulation happens and progesterone gets added to this mix, what happens is that these arterioles and these glands which are in the endometrial glands increase and become very, very tortuous. Can you see this tortuous gland here, the one here, and the arterioles supplying this also become more vascular and more blood supply. So this initial part is called the proliferative endometrium. Okay, and the latter part, under the influence of progesterone is called the secretory endometrium. Finally, what happens when pregnancy doesn't happen? When the hormones go back to normal, they start falling, the endometrium is going to break down, and that leads to the period. So this is what is happening in the menstrual cycle. Now, another important table is this table. This table is very important because it gives you the timelines of when ovulation is happening. So I told you have the estradiol rise, then the estradiol is going to make the LH also rise. So the first peak is the estradiol peak, then you have the LH peak, and somewhere here ovulation is happening. Somewhere here you're having ovulation. So you should know from the LH peak till ovulation, this duration is around 10 to 12 hours. That's important to understand. Okay. And from the estradiol peak till ovulation, this is around 24 to 36 hours. So remember these two. The LH peak to ovulation is 10 to 12 hours, and the estradiol peak to ovulation is 24 to 36 hours. So these two are ones you should remember for sure from this table. Okay. Now, coming to a bit about now what happens during puberty. So during puberty, remember, puberty is affected by a lot of things. One of the primary things that affects puberty, if you want to name one thing, it is the amount of body fat. Okay, so apart from nutritional, which is primary because fat is one of the main things that sets the clock and puberty starts. Okay, but apart from that, you have genetic, environmental, racial, cultural, climatic, and of course age. So this is what happens when we have puberty, onset of puberty. But if you're asked to mark amongst all this, the most important determinant is nutritional or the amount of body fat in the body. Also remember that before puberty, the hypothalamus is highly sensitive to inhibitory effect of gonadal steroids, which keeps the GnRH release under check. So before puberty, nothing happens. Okay. And early in puberty, what happens? The sensitivity decreases. That means the GnRH, now the hypothalamus becomes more and more responsive, and and starts getting secreted. The hypothalamus secretes GnRH, and this is going to increase the FSH and LH secretion, which will of course in turn increase the estrogen and progesterone. And this is what starts puberty. So the HPO axis starts getting activated because of the release of GnRH. Now, remember this, what we talked about in physiology of menstruation is the ovulation. And in ovulation, the LH surge, which happens because of positive feedback of estrogen. This particular mechanism, this LH surge happening because of positive feedback by estrogen happens much later on. That's why the initial few years of puberty, the initial few cycles following menarche are anovular. And it takes time for this to get set in. Okay, so that's important to understand. Now, what are the stages in pubertal development? So the first thing that usually starts is, I told you, the increase in body weight and physical growth starts. So between the age of 9 to 11 and it is completed by the age of 14, there will be certain changes in the body. Okay, and we're talking about girls here because this is a gynae topic. We have the feminine body shape starts appearing, and the growth hormone causes an initial growth spurt. But if you're asked the first sign of puberty, then the answer is breast development, that is THELAC, and that is controlled by estrogen. So question comes, first sign of puberty, the answer is THELAC, followed by adrenac, which is pubic and axillary hair. These are the Tanner stagings. What you're seeing in the diagram are the Tanner stages. Okay, you don't have to know, it's never been asked what is Tanner stage 3, what is Tanner stage 2, but you should know that there are 5 stages in THELAC, 5 in pubic and adrenac. And what you're seeing here is stage 1 is the prepubertal stage. And stage 5 is fully developed breast. So you should know 1 and 2 are like the not developed, and 4 and 5 are fully developed. So you should know if a question comes that a girl comes with primary amenorrhea or delayed puberty, and when you examine her, you find that the breast is Tanner stage 1. You should know what that means. You should know how to interpret in terms of a question. Then finally, what happens? So you have pubic, so you have THELAC, then you have adrenac or pubic, and then you have menarche. Now remember, this whole process takes about 2 to 3 years. In fact, one of the definitions of primary amenorrhea is that there is no menarche even after 3 years of THELAC. So we will take the upper limit between THELAC and menarche as 3 years. So menarche happens approximately 2.5 years after thelak. That is what I said, between 2 to 3 years. The median age being 12 years, okay, which is now becoming lesser than what was earlier. And as I said, the beginning cycles are going to be anovular. Now, there's something called precocious puberty. What is precocious puberty? It is when there's pubertal development, signs of pubertal development occurring before the age of 8 years, or menarche before the age of 10 years. This includes thelarche and adrenarche happening before the age of 8 years, or menarche before the age of 10 years. This is for girls. Now, what should you know importantly in precocious puberty? One is, there are two types. One is called as central, okay, and one is called as peripheral precocious puberty. Central means the problem is in the brain. There's a hypothalamic pituitary problem which is stimulating the release of GnRH or FSH and LH early on. And the most common cause, however, is it is idiopathic. There is no known cause. But sometimes you do, and we have to evaluate for this for a CNS pathology like a tumor, like an infection. So you have hamartomas, you have astrocytomas, you could have congenital hydrocephalus, or you can have acquired because of an infection or because of irradiation. Peripheral means independent of GnRH. This is also called as GnRH dependent causes, is the central causes, and precocious is GnRH independent. That means the problem is not because it's not starting from the brain. The problem is estrogen, progesterone, especially estrogen secretion, is happening elsewhere. So either an ovarian or an adrenal cause is what is causing the estrogen to be secreted. So you have estrogen secreting tumors or androgen secreting tumors, like adrenal causes like congenital adrenal hyperplasia, Cushing syndrome. There's something called as McCune-Albright syndrome, which commonly gets asked in the exam. Then you have exogenous intake of hormones or thyroid disorders. These can all cause peripheral causes of precocious puberty. What is McCune-Albright syndrome? This comes as a question. McCune-Albright is characterized by sexual precocity. So you have precocious puberty plus multiple cystic bone lesions, which is called as, typically described as, polyostotic fibrous dysplasia. And you have these brownish coffee lesions, that is cafe au lait spots on the skin. So if you get an image-based question with an image like this saying precocious puberty, you should know this is McCune-Albright syndrome, which is a peripheral cause of precocious puberty. Now, another part continuing with puberty is, so we have precocious on one extreme, on the other extreme you have delayed puberty, which is amenorrhea or primary amenorrhea is what we start with. So we have the definition of primary amenorrhea, and this is very important. So this whole topic as such, primary amenorrhea, is a very important topic. So I suggest, if you've not gone through this topic from the main lectures, if you have time, do go through it once, because it's number one, it's a vast topic. Number two, it's a very important topic. Okay, so if this is just a revision, and it's good enough for you. But if you feel you are still lacking in this topic, you want to understand more conceptually, then go to the main videos. Okay, but we will try to cover all the important points here which you need to know for the exam. So first of all is the definition. You can make 5 questions just from this slide. Okay, so it's that important. Now, what is the definition of primary amenorrhea? It is, number one, if a girl comes with her mother, and this is how the scenario plays out in the OPD. The mother will bring the girl and she'll be very anxious. She will say, my daughter hasn't got her period. So what you'll see, you'll first ask the age, and then you see what else you see. You see the presence or absence of secondary sexual character. So suppose this girl is 13 years old and she doesn't have secondary sexual characters, then it is important. Then it fits in the definition of primary amenorrhea. Because by the age 13, you expect at least thelarche or pubarche to start. So in the absence of secondary sexual characters, we take the cutoff as 13 years. But if suppose the same girl, 13 years old, you examine her, you find breast development is there, pubic axillary hair has started to grow, then what you do? Then you will say, don't worry, let's wait for some more years. If she doesn't get her period, come back at 15 years. So this is what it is there. So the second definition is, if she comes back at now 15 years, and in the presence of secondary sexual characters, that means pubarche and thelarche is there, but she's now turned 15 and still no period, this is when you say it is primary amenorrhea. A third definition was recently added, and I've told you this: if after thelarche, breast development has started, but 3 years have passed since and no signs of menarche, it is again a definition of primary amenorrhea. So why is this important? Absence of secondary sexual characters. Why are we looking at this? Because when we're not seeing secondary sexual characters, we know there's a problem in the HPO axis, right? So no secondary sexual characters means a problem in the HPO axis. That means there is no exposure to estrogen. And that brings us to this slide. Now, this slide is telling us the problem kahan ho sakta hai. Where can the problem be? The problem can be in a patient who comes with primary amenorrhea. It could be in the HPO axis. See, this is hypothalamus, this is pituitary, this is ovary. Or it can be a problem in the uterus or the endometrium. So, a problem in the uterus or a problem in the outflow tract. There is the uterus might be normal, but there is a blocked vagina. So, the problem in the blood coming out. So, this is where the uterus or the outflow could also be a problem. Okay, and these girls will usually present with secondary sexual characters present, and this group is going to present with secondary sexual characters absent. And that's what's important to understand, because that is how you're going to solve your questions. That is how you're going to think when the question comes. Sabse pehle kya dekhna hai? What do you see first? Are secondary sexual characters there or are they not there? So these are usually referred to as compartment 1 problems, the uterus and the vagina. Compartment 2 is usually the ovary, compartment 3 is usually the pituitary, and compartment 4 is usually the hypothalamus. Okay, now we start discussing the most important anomalies that you should know in and out about. One of them is MRKH syndrome or uterovaginal agenesis, or simply called as Mullerian agenesis. What is happening here? Here you have a person whose uterus hasn't formed. Okay, and the uterus hasn't formed. Along with the uterus, the other components of the Mullerian duct. So in complete MRKH syndrome, you have an absent uterus, an absent cervix, absent fallopian tubes, and an absent upper vagina. All these are going to be absent because these are structures formed from the Mullerian duct. Okay. Now, what is the typical presentation? This is going to be a person who looks like a girl with well-developed secondary sexual characters but primary amenorrhea, because the HPO axis is completely normal. The problem is just an absent uterus. HPO axis is normal. So, secondary sexual characters are going to be completely normal. So, normal. So, it is normal secondary sexual characters with primary amenorrhea. And remember, it's the second most common cause of primary amenorrhea. What is the most common cause? The most common cause is Turner syndrome. Second most common cause, Mullerian. When you do a karyotype, you'll find she's 46XX. She appears female. Even her external genitalia is going to be female. But the vagina, since the lower part has formed, it's going to be a small vagina which could be blind. When you try to do an examination, and in these girls, it's very difficult. The vagina is not there or very small. How do you know if a uterus is there? So we usually do a per rectal examination if they allow. Okay, it could be quite uncomfortable, and you look for the presence of a uterus anteriorly. But sometimes this is not possible, so you get an ultrasound and look for the presence of a uterus, and you will find an absent uterus. Uterus will not be there. But the ovaries are going to be completely normal on the ultrasound because the ovaries are not the problem here. If you do a hormonal profile, you will find normal FSH-LH and you will find normal estrogen. So, normal. And very commonly asked question is, such a girl will have 30%, in fact, will have associated renal anomalies, and 15% will have associated skeletal abnormalities. How do you treat these girls? You are going to, so several questions can come from treatment also. Now, the first thing that the parents are usually worried about is, can she get her period? And the answer is no, because she doesn't have a uterus. Then the second question, especially in our society, very commonly, can she get pregnant? And the answer is yes. How can she get pregnant? So there are two ways she can get pregnant. One is surrogacy, that is gestational surrogacy. You borrow somebody else's uterus. She has ovaries, so you take her eggs, and through IVF, you get the embryos made and then transfer the embryos into somebody else's uterus. This is called as gestational surrogacy. But MRKH is now a known indication for something called as uterine transplant. In the past 5 to 6 years, several have been done the world over. Several have been done in India also. So it's now an upcoming possibility. Although is done 1 or 2 centers in India, and it is quite expensive. Now, a third thing which the parents may not ask, but you should know because the girl may ask you later on in life, is sexual function. Because the vagina is very small, it's a short vagina. How can she have penetrative intercourse? And the answer is by giving her a good length of vagina, and that is by doing what is called a vaginoplasty. This can be done surgically, and surgically it's called a Mackindow's vaginoplasty. That means you're creating a vagina or lengthening the existing vagina. Or you can do non-surgical, that means give her dilators, vaginal dilators. If there's some length, dilators may be a possibility, and gradually over time, with gradual dilatation, the vaginal length will increase. So this is MRKH syndrome, what you should know about MRKH syndrome. The second type of anomaly is the imperforate hymen and the transverse vaginal septum, which I've discussed in Mullerian also, but I'll discuss here also. Imperfect hymen, how is this girl going to present? This girl is going to present, as again primary amenorrhea with secondary sexual characters, with cyclical abdominal pain. That means she's having her period, but the blood can't come out. That's why she has cyclical abdominal pain. And this is called as cryptomenorrhea. Crypt means hidden and amenorrhea. So hidden period is what is seen in her. Okay. Another few symptoms, she may also have retention of urine because of the pressure of the bladder by the hematocolpos. What is hematocolpos? It is blood in the vagina. Bahar nahi aa raha, it keeps collecting in the vagina. And secondly, she has a suprapubic bulge. So what you find in this girl is a girl who comes with any of these symptoms, and it's very commonly asked in the exam. They'll either ask retention of urine, or they'll say suprapubic bulge, or they'll give you cryptomenorrhea. One of these will be asked. And when you examine her, what will you find? You'll see this typical picture. This is the bluish bulge, because the hymen is a very thin structure. So you'll see this bluish bulge. Why blue? Because of the accumulated blood in the vagina or hematocolpus, which you see. Okay. Now, another examination you can do, okay, which has come in the exam earlier, is you do a per rectal examination. Now, look at this picture. I'm drawing the uterus here. Okay, this is the uterus. This is the vagina, and here is the obstruction right at the introital level. Okay, so you have blood accumulating all here. Now, suppose you do, behind the uterus is the rectum. Suppose you do a per rectal examination for this girl. Okay, because PV you can't do, there's a blind, it's the hymen is imperforate. You do a PV here, you do a PR here, a per rectal examination. What will you feel in imperforate hymen? You will feel a bulge in the posterior vaginal wall, and that bulge will be all along the length of the vagina. It will be pressing into the rectum posteriorly. So all along the length of the vagina, if you feel this bulge, then you know the obstruction is very, very low down. So an imperforate hymen and also a low transverse vaginal septum. So a low transverse septum is going to be a septum which is going to be at this level. It's going to be low. So these two are very common, have very common clinical presentations. A low transverse septum and an imperforate hymen present very, very similarly. That means they will have the same symptoms, and when you do a PR, you'll feel the bulge all along the length of the vagina. But in a TVS, you usually won't see the bluish bulge because the septum is quite thick. You may not see the bulge this bulge. You may not see it in TVS, but you will definitely see it in an imperforate hymen. If you're still in doubt, an MRI is the best way to tell whether it's a bulge or whether it's an imperforate hymen or whether it is a transverse vaginal septum. What is the treatment of before that, remember that if the obstruction is higher up, that means if it's a mid TVS or a high TVS, so as the obstruction goes higher and higher up, you're going to feel the bulge on per rectal higher and higher up. It won't be felt along the entire vaginal wall, then only higher up. So that's an important differentiating factor to know where the level of obstruction is. Now, if you have an imperforate hymen like this, how do you treat this? What is this? This is called a cruciate incision. So you give a cross-shaped incision like this. Okay, open up the flaps and let all the hematocolpos drain. This is called as hematocolpos. If hematocolpos is not relieved, what's going to happen? You're going to have hematometra. If hematometra is not relieved, you're going to have hematosalpinx. So you have an obstruction which keeps going higher and higher and higher. Okay, so that's also important to understand. And finally, what happens? All these obstructive anomalies will eventually form endometriosis because of the theory of retrograde menstruation. So, an imperforate hymen, a transverse vaginal septum, a vaginal atresia, a cervical atresia will all eventually lead to endometriosis. Now, we're coming back to primary amenorrhea. One of the main problems seen in the uterus was an absent uterus. Another condition where you can see an absent uterus with secondary sexual characters present is androgen insensitivity syndrome. Now, what is this? Remember, this is what we're talking about: complete AIS. Complete AIS means that their androgens are there. Okay, and these androgens are there because this is a 46XY person. This is not 46XX. You have a male karyotype here. The gonads are the testes. There are no ovaries. They are testes, but they are not able to act. The testosterone released by these testes are not acting on where they're supposed to act because the receptors are insensitive. Okay, so this is called as AIS. Now, this is an X-linked recessive disorder. This has come as a question because of an abnormality in the receptor. Karyotype is 46XY. This has come as a question. Remember, jahan pe Y hai, that is XY. So, 46XY, androgen insensitivity. External genitalia is going to be female or male? This is going to be female because although there's testosterone, it's not able to act anywhere on the body. So, it's going to follow the default pathway, which is that of a female. Secondary sexual characters are present or absent. Secondary sexual characters are going to be present, but only mainly the breast. Pubic hair and axillary hair are usually absent. And why is breast development there? Because pubic hair, axillary hair is dependent on the androgen receptors. That's why they're not there. Breast development क्यों हो रहा है? Because the testosterone, which is unable to act on where it should act, in turn starts getting converted to estrogen, and this estrogen is what is going to cause the breast development to happen. So it may not be a very good Tanner 4 or 5, but till Tanner 3 you can see breast development, and that's a very important feature. So thelarch is there, breast is there, but pubic axillary hair is very sparse or absent. If you do our hormonal levels, you'll find the FSH is moderately high and the testosterone levels are normal for the male value levels. How do you manage this girl? Because she's been brought up as a girl, so we will call her a girl. You manage her by, again, can she get pregnant? No, she can't get pregnant. So no pregnancy because she doesn't have ovaries, she doesn't have a uterus. There's no possibility. Can she get her period? No, she can't get her period because there is no uterus, no ovaries. Can she get sexual function? Yes. So again, here you're going to do a vaginoplasty. And very importantly, in these XY individuals who have these kind of presentations, you're always going to do a gonadectomy because these gonads which are not functional 20% of them will end up harboring a malignancy. So gonadectomy should be done, bilateral, remove the gonads, do a vaginoplasty, and that is what is important. Now, there's a small category of patients called partial AIS. Partial AIS means some androgen sensitivity is there. So some action is there. And these usually present with signs of virilization at puberty. That means there will be hoarseness of voice, there will be clitoromegaly. So some ambiguity in the genitalia will start appearing at puberty. Otherwise, this is very similar to complete AIS. Now coming to the problems in the ovaries. Whenever there's a problem in the ovary leading to primary amenorrhea, it's called as, or a problem in the gonad, I would rather say, it's called as gonadal dysgenesis. Okay, so there is abnormal development of the gonads and secondary sexual characters as a result are going to be present or absent. They're going to be very good. They're going to be absent. So absent secondary sexual characters is what forms the basis of diagnosing gonadal dysgenesis. Estrogen levels, FSH, LH levels. So if the ovary is problematic, what's going to happen to estrogen? It's going to be less. Okay, and as a result, the FSH, LH is going to be high. This scenario is called as hypergonadotrophic hypogonadism. Okay. So, gonadotrophs are the FSH-LH. So, hypergonadotrophic hypogonadism. And the most common type of gonadal dysgenesis is 45XO, that is Turner syndrome, where you find the streak ovaries, where all the girls are short, There will be streak ovaries, there will be web neck, there will be shield-like chest, there will be coarctation of aorta, there will be cubitus valgus. So many features are there which you already know. Management of these people. So if you have a 46XY gonadal dysgenesis, and this is called as Swyer syndrome, here you're going to do a gonadectomy. Okay, but usually all the gonadal dysgenesis, whether it is 46XY, 45XO, 46XX, all these, what are you going to do? You have to give them estrogen or estrogen plus progesterone if they have a uterus, and basically hormone replacement therapy needs to be given. So you're going to give estrogen plus progesterone, that is HRT, to these girls so that secondary sexual characters can develop. So another important type of syndrome which is affecting the HPO axis, that is the hypothalamus, is called as Kallmann syndrome. Here there is the hypothalamus is affected, so GnRH is not being produced. So FSH and LH are going to be low, and as a result estrogen is also going to be low. So all these are low, and this is called as hypogonadotrophic hypogonadism. So if there is a problem in the FSH, LH, and in the hypothalamus pituitary leading to reduced FSH, LH, this is called as a hypogonadotrophic hypogonadism. So, and typically with Kallmann, you see this picture. So, clinical question will come with anosmia, or they may even be sensory neural hearing loss or cerebellar ataxia or clefting, cleft lip, cleft palate, along with primary amenorrhea. Always think of Kallmann. So, primary amenorrhea is the rule. Now, before we go further, so let's discuss a bit about sex disorders of sexual differentiation, because although it's very important from I&I point of view, a bit of it you should know for your NEET PG FMG exams also. So what you have is you have something called the genetic sex. What is genetic sex? So the genetic sex is what is the genetic, the karyotype of the embryo. That could be 46XY. Or it could be 46XX, right? So 46XY is the male karyotype, 46XX is the female karyotype. So this is the genetic sex, and this is going to determine what the gonadal sex will be. What is the gonads? The gonads could be the testes or the ovaries, and if it is a 46XY, the gonad is going to be the testes. If it is 46XX, the gonad is going to be the ovary. So this is the genetic sex. Now remember, the gonads are bipotent. That means they are undifferentiated till when? Till 5 weeks of gestational age. Till 5 weeks, you don't know what they are. Only at 5 weeks, if it is 46XY, the gonad becomes the testes. If it is 46XX, the gonad becomes the ovaries. Now let's discuss what happens in the 46XY individual. In the 46XY individual, where the gonad is the testes, what is happening here is that the testes gets differentiated by 5 weeks, and the testes has what determines actually what this embryo is going to be. Remember, the 46XY embryo has what is called the SRY gene, or the sex determining region on the Y chromosome. It's on the short arm of the Y chromosome. Okay, and this is actually where everything starts. This is what is going to determine the gonadal sex, and from here everything else starts. So in the male, where the SRY gene is going to be present, the gonad is going to be the testes. The testes is going to release two hormones. It's going to release from the Leydig cell, it's going to release the testosterone, and from the Sertoli cell, it's going to release a hormone called the anti-Mullerian hormone. What does the testosterone do? Testosterone is going to cause differentiation of the Wolffian duct, okay, into the internal male genitalia. Okay, and the Wolffian duct, which forms the internal male genitalia, forms what all structure? It forms the vas deferens, it forms the seminal vesicle, and it forms the epididymis. These are the three structures formed by the Wolffian duct. What does the AMH do? AMH is going to cause anti-Mullerian growth. That means it's going to go and inhibit the growth of the Mullerian duct. Okay, so that means the uterus won't form, because the uterus forms from the Mullerian duct. So the uterus and the structures related to the Mullerian duct will not form, but what is going to form is the Wolffian duct, right? What else is happening? The testosterone gets converted by the enzyme 5-alpha reductase to dihydrotestosterone. And this DHT is what is going to cause development of the male external genitalia and the prostate. So the male external genitalia and the prostate starts forming because of dihydrotestosterone, which is converted by testosterone under the influence of the 5-alpha reductase enzyme. Now remember, the internal genitalia, and this is very important. So the gonads are bipotent till 5 weeks. The internal genitalia, that means both Wolffian and Mullerian duct exist. It is bipotent. That embryo is bipotent with respect to internal genitalia till 8 weeks. That is when differentiation of one and regression of the other starts. And the external genitalia is bipotent till 9 weeks. That means till 9 weeks, the embryo looks the same externally, male or female. Only at 9 weeks does the development of the external genitalia start. So this is what is happening in the male, in the 46XY. What's happening in the female, in the 46XX? What's happening? Now, in the 46XX, there is no SRY gene. So the gonad that is going to form is the ovary. Now, the ovary doesn't secrete anything. It doesn't need to. It's a female. Female is a superpower. It doesn't have to do anything. So the ovary is just sitting as it is. So there is no testosterone and there is no AMH. So what's going to happen? No testosterone, so the Wolffian duct won't develop. Wolffian duct is going to regress. There is no AMH. So there's nothing opposing, there's nothing opposing the Mullerian duct. So the Mullerian duct is going to grow. Okay. And what else is happening? You have the external genitalia. Again, there is no testosterone. So what's going to happen to the external genitalia? It's going to take the default pathway, which is the female. Female is the default pathway. Okay. So everything is now going to go towards being a female. And that is because there is no testes. The gonads are the ovaries. So in the female, it's very simple. It's very straightforward. This is what is happening. Now, there is a condition called Swyer syndrome. What is happening in Swyer syndrome? This is 46XY gonadal dysgenesis. And what is happening in 46XY gonadal dysgenesis is that it is a 46XY. That means the gonads are the testes, but the testes are not functional. It is dysgenetic. It is not a functional testes. So what is happening? There is no testosterone and there is no AMH. So what's happening? You have a gonad, you have an individual who has a testes as the gonad, but because it doesn't have a working testes, there's going to be no Wolffian duct development, and you have no AMH. So what's going to happen? You're going to have Mullerian duct growing. So you have a 46XY individual with a uterus with primary amenorrhea. That's going to be the end result with no secondary sexual character development. That is Swyer syndrome. So 46XY gonadal dysgenesis, an individual with primary amenorrhea with a uterus with no secondary sexual characters, and the karyotype is 46XY. So that is another important thing you should know. Now, moving on to these two important flowcharts. If you understood till now, and if you just go through these two flowcharts and apply their use to your clinical questions, you can answer most of your questions. Now, normal secondary sexual characters, this arrow is downwards, apologies. If you have a woman or your question comes with primary amenorrhea with normal secondary sexual characters, the first thing you're going to look for, that means the HPO axis is normal. So now you're worried about the uterus and the outflow, remember? So what will you do? The first thing you do is you'll either look for whether the question gives us the presence or absence of a uterus. So look for a PR examination, look for an ultrasound. A question can come just straight from here and say, what next? What is the next best step? Next best step is look for the presence or absence of a uterus. If a uterus is absent, what will you do? Here we need to think of two things. Secondary sexual characters, present, uterus, absent, it's either MRKH or it is AIS, androgen insensitivity. And the only way to differentiate between the two, not the only way, one of the best ways is by doing a karyotype. And the karyotype, if it is 46XX, it is MRKH. If it is 46XY, it is AIS. Why did I say not the only way? Because another way you can differentiate is by looking at the gonads. If the gonads are ovaries, it is MRKH. If the gonads are testes, it is AIS. And if the uterus is present, then it's probably a problem in the outflow. So look if any clues are given towards cryptomenorrhea. Is there an outflow obstruction? Maybe it's imperforate hymen, maybe it's a TVS. But if everything is normal, uterus is normal, no outflow obstruction, then it just may be constitutional. Wait for some more time, she'll get her period. Or sometimes it could be early PCOS or maybe a hyperprolactinemia. So this is the flowchart for primary amenorrhea with normal secondary sexual characters. Next we come to primary amenorrhea with absent secondary sexual characters. Again, the arrow is wrong. The first thing we look for in such a scenario is the height. Is the height given? Because remember, if the height is short, Turner syndrome are short girls. All Turner syndrome girls are going to be short. But how do we still confirm? See if the FSH is given. So if the FSH is high, that is pointing towards Turner syndrome. If the FSH is low, however, that means the problem is again higher up, somewhere in the hypothalamus and the pituitary. A high FSH with a short height with secondary sexual characters being absent is definitely going to be Turner syndrome. If the height, however, in the question is given to be normal, still we need to know where the problem in the HPO axis is, because we know now if the secondary sexual characters are not there, the problem is of course in the HPO axis. The height being normal, we will still do an FSH to determine if the problem is in the ovaries or in the hypothalamus pituitary. If it's in the ovaries, the FSH is going to be high, and if it's in the hypothalamus pituitary, the FSH is going to be low. So high FSH with normal height will be not Turner's but either a pure gonadal dysgenesis, that is 46XX, or a Swire syndrome. So now moving to secondary amenorrhea. Now secondary amenorrhea means when a woman hasn't got her period for 6 or more months. And it's important to understand how we go about evaluation, because although primary amenorrhea is commonly asked in the exam, we do get occasional questions from secondary amenorrhea. Now you should know that the most common cause is of course pregnancy. So the first thing you should look for is if the option is mentioning pregnancy. Once pregnancy has been ruled out, there are two other important things we rule out, that is thyroid disorders and hyperprolactinemia. Okay, so this can also cause secondary amenorrhea. Once these three causes have been looked into, what's the next best thing we do? The next best thing is we do a progesterone challenge test. What does that mean? This means we give the woman a course of 7 to 10 days of progesterone and then see if she has bleeding. If she bleeds, what does this mean? That means she was progesterone deficient. And which women are progesterone deficient? Those who are having anovulation or anovular cycles, like in PCOS. So PCOS is a common cause of anovulation. Other common causes of anovulation are during puberty, few years following menarche, and even in the perimenopausal age group. Now, if she doesn't bleed, there's no bleeding on giving progesterone, what do we do next? We give her estrogen and progesterone. So we give her both estrogen and then progesterone, and then see what happens. Now, if she bleeds on estrogen plus progesterone, that means she was estrogen deficient also. And what could be a possible cause? That means there's a problem in her HPO axis. So how do we know where the problem is in her HPO axis? We get a FSH done. If the FSH comes as low, that means the problem is probably in the hypothalamus or pituitary, and a common pituitary cause of secondary amenorrhea is Sheehan syndrome. Okay, but if the FSH levels are high, that means the problem is in the ovaries. Okay, that's why there is no estrogen, leading to a high FSH level. And here, what will you think of? You'll think of premature ovarian failure, like Turner mosaic, right? Like fragile X premutation, or some radiotherapy, chemotherapy to the patient, leading to premature ovarian failure, or if there's a family history of menopause at a young age. Okay, so that is when she bleeds. So if she bleeds, that means there's a problem in the HPO axis. How to identify where the problem is? By doing an FSH. FSH is low, problem is in the hypothalamus pituitary. FSH is high, problem is in the ovaries. What if she doesn't bleed? There's no bleeding on giving estrogen or progesterone. That means the problem is in the uterus. And in the uterus, what do you think of? For secondary amenorrhea, you think of Asherman syndrome or a chronic endometritis like genital tuberculosis. These are the common causes of secondary amenorrhea, which are uterine causes. Asherman's are intrauterine adhesions. There's usually a history of a DNC followed by secondary amenorrhea, or there is a history of genital tuberculosis leading to chronic endometritis. Now, very important to know is that the normal FSH levels, because the questions that come these days, they will just give you a value. You should know what is normal or abnormal. A normal FSH lies between 1 to 10. Okay. If it's more than 10 or especially more than 20, that means the value is very high. If it's less than 1, the value is very, very low. So these are normal values. Anything between 1 to 10 is a normal value, and you should consider it normal. And you should look, if the FSH values are normal, you should think of a uterine cause. Now a bit about PCOS. So we'll cover PCOS here only. This is the typical polycystic ovary or polycystic morphology on the ultrasound, the necklace pattern, the string of pearls pattern, all that. To diagnose PCOS, we have the Rotterdam's criteria, and Rotterdam criteria says that 2 out of 3 have to be there of. Number 1 is oligo or an ovulation. That means she's having delayed cycles once in 2, 3, 4 months, or she's not got her period for a long time. Secondly, there is clinical or biochemical evidence of hyperandrogenism. That means clinical evidence means acne, hirsutism. Biochemical evidence means a raised testosterone or a raised DHEAS level. Okay. And third is you have the polycystic morphology. That is this picture on the ultrasound. Any 2 of 3 if they are there. And polycystic morphology could be in either one or both ovaries. It doesn't have to be necessarily in both the ovaries. Even one ovary you find it, it is polycystic morphology. So 2 of 3 is Rotterdam's criteria. Now common questions that come these days are on management of PCOS. And to simplify this topic, it's very important to understand that the primary management goal, the main management goal on top of which everything else is lifestyle. We know that PCOS is very commonly associated with a high BMI. So you're going to reduce her BMI. You're going to tell her to start diet and exercise, and this is going to form your mainstay of management. Lifestyle, diet plus exercise has to be done. There is no, if this is the option, this will be the best option. Okay, irrespective of what her complaint is, always look for this option. The next depends on her age, okay, and her symptoms. Okay, so let's start with the young woman. The young woman who's probably unmarried or not, or married but doesn't want children, so not interested in fertility. This question can come. She can have 2 complaints. Either she has oligomenorrhea or delayed cycles, or she has acne, hirsutism. This is how the common presentation would be in this age group. So in either of them, what are you going to do? If she has delayed cycles, what will you do? You will give her combined oral contraceptive pills. If she has acne and hirsutism, you give an anti-androgen, but we don't give plain anti-androgen. We give it along with an OC pill where the progesterone component is an anti-androgen, which we commonly give an ACE OC pill containing a 4th generation progesterone, that is drospirenone. Okay, and this is, so we give OC pills basically for both the things where the progesterone itself is an anti-androgen. If this doesn't work for her acne or hirsutism, then to this we may add an anti-androgen, but the primary management is always an OCP containing an anti-androgen. This could be drospirenone or cyproterone acetate. Okay. Now the second group of people are those girls who are wanting fertility. They are not able to conceive because of anovulation. In this group, again, primary for both groups is lifestyle. Dono groups mein you're going to first emphasize lifestyle. So lifestyle plus OC pills. Lifestyle plus, in the second group, you're going to give her ovulation induction agents. And we'll be discussing this in a bit when we come to infertility. Here the drug of choice is what? The drug of choice is letrozole. Okay, which we give from day 2 to day 6. 5 days we give 2.5 milligram per day. And then we call her for follicular imaging, which we will discuss in a bit. So the drug of choice is letrozole. And if this fails, we can even try clomiphene citrate. If this fails, you can even do laparoscopic ovarian drilling, or you can consider giving her gonadotropins, that is FSH or FSH plus LH directly. Okay. And also sometimes there's a role of adding an insulin sensitizer like metformin. Now, the third group of people are those who are not even bothered about fertility. They have reached the age where their main concern is now what will happen in the future. So, the older woman. In the older woman, where acne, hirsutism, oligomenorrhea, fertility is not a concern, but you need to tell this group of patients, and along with other things, is that she's at risk for two things. She's at risk of metabolic syndrome. So, you want to prevent metabolic syndrome, and this is again explaining lifestyle. And she's at risk of endometrial cancer. Okay, and now endometrial cancer is because of unopposed estrogen. There's no progesterone, so estrogen keeps lining the endometrium, makes it thick, and finally she develops endometrial cancer. So how do you prevent endometrial cancer? So for metabolic syndrome, and metabolic syndrome, remember, is important for all the groups. You have to counsel all the groups for metabolic syndrome, and lifestyle helps plays the most important role here. But for preventing endometrial cancer, you have to make sure that she bleeds at least every 3 months. So you give her withdrawal bleeding with progesterone every 3 months. That means at least 4 cycles per year. She has to have at least 4 cycles per year to prevent endometrial cancer. That's the aim in the older woman. So this is management of PCOS in brief. The 3 main categories that are usually asked in the exam, a clinical question will come. Remember, lifestyle management is paramount, because apart from reducing metabolic syndrome, it usually helps in the other symptoms as well. Okay, now we move on to another very high yield topic, that is Mullerian anomalies. This is the recent most classification. There are many classifications which came in between the SRA, the ASRM. Now the ASRM 2021 has come out, which is more of a app. It's a tool. It's a tool which is on an app, and you can find it on your phones. And these are the classification categories. So there are now 9 categories. Mullerian agenesis, cervical agenesis is separate, unicornuate, didelphys, bicornuate, septate. Then they've divided the septums. Longitudinal septum is one category, transverse septum is one category, and then complex anomalies in one category. Now, MRKH we have discussed in detail, so I won't go there. We start with unicornuate uterus. Unicornuate uterus is when you have the Mullerian duct development, you have 2 Mullerian ducts, and each develop and then they fuse to form one uterus, right? Now, in unicornuate uterus, what happens? Only one Mullerian duct develops. The other regresses, or it may form a small horn attached to the main uterine cavity. Now, unicornuate uterus presents very commonly with either recurrent abortions. In fact, before this, it can present as infertility. It can present as abortions. It can present as preterm labor, as fetal growth restriction, and as malpresentations. Okay, so this is how unicornuate uterus will present. But if there is a rudimentary horn, okay, look at these first 3 pictures. This is a communicating horn. This is a non-communicating horn, but which has a functional endometrium. This is a horn which has no cavity, nothing inside, just a horn attached. And this is no horn. Okay, so in fact, the majority, almost 65% of unicornuate uterus will have a horn. And if it has a horn, then you have several problems. So if it has a horn which is communicating and has a cavity, here the problem you can have here is you can have an ectopic pregnancy in the rudimentary horn, which typically presents as a mid-trimester rupture of the horn and hemoperitoneum or shock. Patient coming in shock in the second trimester, always think of a pregnancy in a rudimentary horn. The second type, where it is non-communicating but having functional endometrium, what's going to happen? This is going to bleed, and she's going to have a small hematocolpos, which will eventually may lead to endometriosis. So she's going to have cyclical abdominal pain, but she's not going to have primary amenorrhea because one horn is completely functional. The pain is because of the other horn. So worsening dysmenorrhea, endometriosis, always think of a possible horn. It's another obstructive type of Mullerian anomaly. Usually this one will not present any other significant symptom other than these symptoms. Okay, and this also will not have any other significant symptoms. Now, if there is a rudimentary horn, if you diagnose a rudimentary horn, you have to excise it either laparoscopically or laparotomy. Excision of the horn has to be done. Otherwise, per se, for unicornate uterus, there is no surgical management which is evidence based, which can increase the size of the cavity. Now you have the second one, didelphys. What is didelphys? You have the two Mullerian horns, but each of them have grown separately and are now independent of each other. They haven't fused. Now, didelphys, as per Williams, typically presents with three complications: abortions, preterm labor, and malpresentations. These are the three common, I won't say common because didelphys usually has a good reproductive outcome. But if there are problems, these are the three problems that are encountered. Okay, now here another important or a variant of uterine didelphys, a very rare variant. So a rare variant of uterine didelphys is the O-Vera syndrome. What is the O-Vera syndrome? O-Vera syndrome is when you have the didelphys, okay, and you also have, so OHV means obstructed hemivagina. That means part of the vagina is obstructed, and IRA is ipsilateral renal agenesis. So on that side there is absent kidney. So on the side of the obstruction there is an absent kidney, and what's going to happen here? It's again an obstructive type of Mullerian anomaly. So you're going to have a bit of hematocolpos, you're going to have hematometra, you're going to have hematosalpinx, and finally endometriosis. So endometriosis can be seen also very, very rarely though in didelphys. Okay, so all four can be seen. This is what Williams gives. Endometriosis is a rare thing which can happen in O-Vera, which is also quite rare. So this is about uterine didelphys. Again, no surgical method to correct this has been found to be of any use, but it usually doesn't have many problems also. Next is bicornuate uterus. Look at this. This is bicornuate. What happens is the two Mullerian ducts have fused, but the fusion is incomplete. This leads to a bicornuate. Again, it can present with infertility. It can present with recurrent pregnancy losses, usually in the second trimester, like cervical insufficiency. It's very commonly associated with cervical insufficiency. Then you can have preterm labor, fetal growth restriction, and again malpresentations are common. What do you do for these patients? So one rare type of surgery which can be attempted is Strassman metroplasty. That is bringing the two horns together and joining them. Okay, but it's only done if and only if RPL is there, recurrent pregnancy loss, with all other possible reasons being ruled out, then this could be a rare type of surgery which can be attempted. Now coming to septate uterus. Septate uterus, what happens in septate? The two horns have fused, but the septa which is in the middle, which is supposed to dissolve, does not dissolve. It remains there. And if it doesn't dissolve, this is called a septate uterus. Now, so when you do a HSG, it's going to appear like this. Look at bicornuate uterus. The angle between the two horns is 105 degree, or it's a wide angle. But look here, this angle is an acute angle, less than 75 degree, you will call it a septate uterus. More than 105 degree, you will call it a bicornuate uterus. Okay. Now, in septate uterus, remember that this woman will again present with the same set of complications. Infertility is common, abortions and recurrent pregnancy loss is common, preterm labor is common, IUGR is common, malpresentations is common. What is the best way to diagnose this? So HSG gives you an idea, but if you're doing a diagnosis, a hysterolaparoscopy is the best way to actually differentiate or to actually see what this is. Okay, so on a hysteroscopy, what are you going to see? On a hysteroscopy, you're going to see this. You can see this central septa, which is avascular. You see it here, and you see two cavities. And in the same patient, if you do a laparoscopy, you're going to see a broad fundus. Whereas in bicornuate uterus, you'll see two completely separate funduses on laparoscopy and a similar picture on hysteroscopy. On HSG, this is important because this has been asked in the exam. How will you differentiate between these three? Didelphys, you can see there is no communication between the cavities at all. Bicornuate, the angle is wide. Septate, the angle is narrow. So if you're asked the best non-invasive investigation HSG is not the answer. HSG very poorly differentiates between the three. The best answer would be either an MRI or a 3D ultrasound. Okay, I would still put an MRI above a 3D ultrasound. But the best invasive and the best overall investigation would be to actually put in a laparoscopy and a hysteroscopy and look from the inside of the uterus, look from the outside, and determine what the anomaly is. Now, one of the best anomalies, in fact, the best anomaly which has no abnormal outcome, it's just a finding, is a slight indentation or a heart-shaped uterus like this. This is called an arcuate uterus. It has no adverse clinical outcome, or the best outcome is with an arcuate uterus. Now, questions also come on this. This is a DES, diethylstilbestrol, was a drug given in the 1950s and 60s in women who had recurrent pregnancy losses. Okay, like how we give progesterone now, that time they used to give DES. But it was found that girls and boys born to mothers who received DES had anomalies. So this is actually a highly teratogenic drug. And what anomalies were found? In the girls, they were found to have T-shaped uteruses. They were found to have clear cell adenocarcinomas later on in life of the cervix and the vagina. And men or boys were found to have hypospadias and microphallus. So it was one of the most classical teratogenic drugs which has been studied. Now, we've already discussed transverse vaginal septum. Okay, it will present very similar to an imperfect hymen, except the bulge won't be seen. And depending on where the level, is it a low, is it a mid, or is it a high TVS, you'll find the hematocolpos higher up. As you go higher, the hematocolpos and the obstruction will be higher up. That's important. What is the treatment? So, the investigation of choice is an MRI. Treatment is excision of the septa, and so that doesn't form again, we usually line the vagina with a graft. Okay, so this is what is usually done for a transverse vaginal septum. Now, in longitudinal vaginal septum, what happens is you have the uterus and you have the vagina and you have a septa like this. Okay, now longitudinal vaginal septum doesn't cause much problem, and it may not be diagnosed till the girl becomes sexually active, where she may have dyspareunia. Okay, or sometimes the septa is only for some extent, only in the upper part. Then what problem may she have? Then they may actually come even late in labor with obstructed labor. And what do you do when you see the septa and the head coming down? You just have to cut the septa. Even if she is not pregnant, you just have to cut the septa. So very easy treatment, just cut the longitudinal vaginal septa. Now, coming to another very important high-yield topic, that is vaginal infections. And starting with bacterial vaginosis. Bacterial vaginosis, remember, presents as white, thin, homogeneous discharge which is foul smelling, but there is no other symptom. No dysuria, no erythema when you examine, no redness of the vagina, and this pH will be on the higher side. To diagnose BV, which is basically an alteration in the normal bacterial flora of the vagina, we diagnose this by Amsel's criteria. What is Amsel's criteria? You have to have 3 out of 4 of clue cells, of the pH being high, of the presence of whiff test. If you add potassium hydroxide, you get a fishy odor, and the typical milky white discharge. 3 out of 4 is Amsel's criteria. And the treatment, what is the treatment? The treatment is giving metronidazole. Okay. The second important infection is trichomoniasis. Now, trichomoniasis presents as a yellowish green frothy discharge. Okay, and patient will be very troubled because she'll have a lot of itching, there'll be a lot of dysuria, and when you examine her, you will find the vagina will be studded by red spots, what is called as a colpitis macularis or a strawberry vagina. Again, pH is on the higher side, and when you prepare a smear, there you'll see clue cells. Here we see the motile organism. So here you see clue cells in BV. Here you actually see the flagellated organism, Trichomoniasis vaginalis. And the third is candidiasis. Candidiasis, we all know, is thick, curdy, no foul smell, but she will be troubled with itching. And when you examine her, the vagina will be very, very red. Okay, the pH here is going to be acidic. So this is seen an acidic pH. And when you do see the smear, you find the pseudo hyphae or the spores on the smear. So here you see the different pictures when you prepare a smear. The first one is showing the clue cell. What is a clue cell? It is a vaginal epithelial cell, okay, which is not having clear margins. Why? Because it is studded on the surface by multiple bacilli, okay, which basically surround the vaginal epithelial cell. So the margins become blurry. This is called a clue cell. Look at the second picture. You can see the flagellated organism. You can see the trichomoniasis with the flagella here. Okay, so this is a typical slide of Trichomoniasis vaginalis. Now, I forgot to tell you what is the treatment of Trichomonas vaginalis. It is also metronidazole. So, in BV, also the treatment is the same, but in TV, remember, in Trichomoniasis, remember, we also always treat the partner. The partner has to be treated because this could be this is a sexually transmitted disease where expedited partner treatment is required. Where all do we treat the partner? We treat in Neisseria, gonorrhea, and chlamydia trachomatis, and also Trichomonas vaginalis, which are all sexually transmitted diseases. The last slide is showing the spores and the hyphae of candidiasis. And here, what do we do? How do we treat this? We can either give antifungal, so oral fluconazole or vaginal clotrimazole is what is given. Now coming to the next topic, which is infertility and what is important here. Remember, infertility is defined as, or the evaluation starts if the couple is unable to conceive after 1 year of unprotected coitus, but we can start evaluation earlier after 6 months in women who are more than 35 years of age or women who have a menstrual irregularity. Okay, so if you have a frank patient who's having frank oligomenorrhea, then you won't wait for 1 year. You'll start evaluation at 6 months because you know she may not be ovulating, or if she's more than 35. But if everything else being fine, she's less than 35, you can easily wait a year for her to conceive. But if she has infertility, what is your evaluation? How will you go about evaluating her? So we are going to look at 4 things primarily. We're going to look at the female factor and the male factor. In the female factor, we look at ovulatory disturbances where we check whether she's ovulating or not. Primarily, how do we check for that? We do a history. A regular cycle will tell you that she's ovulating. You can ask her to check her temperature, basal body temperature, or urine LH kits. Further tests you can do are the day 21 progesterone level. You can do an ultrasound and check for follicular imaging. You can do an endometrial biopsy, or you can get a hormonal profile done. Uterine factor is usually checked primarily by a transvaginal scan. You can also get these other investigations. Tubal factor is the initial test, remember, is always an HSG, but the best test is a laparoscopy with chromotubation. Okay, and male factor, the most important test is getting a semen analysis done. Now, let's go a bit more into these tests. But remember, for the ovary, we had tests of ovulation, but also there's something called as tests for ovarian reserve. As a woman ages, the number of oocytes in her body keep coming down and down. At birth, there are 1 million oocytes in her body. When a girl is born, she has 1 million oocytes. The maximum number of oocytes are, however, much earlier than birth. At 20 weeks of fetal life, she has 6 million oocytes. They keep undergoing apoptosis. So at birth, she is born with 1 million. Okay, at puberty, she is left with 400,000, and at menopause, she has only 400. So that's how the ovaries keep getting depleted of oocytes. So when you have a couple and where the woman's age is on the higher side, more than 35, or she has not been responding well to ovulation induction or controlled ovarian hyperstimulation, it's a good idea to check her ovarian reserve. How do we check the ovarian reserve? There are different tests. The biochemical tests include a day 2 FSH, a day 2 estradiol, and if they are on the higher side, it is a sign of poor ovarian reserve. Remember, these are being done on day 2. Day 2 FSH, day 2 estradiol. If they are high, it is indication of poor ovarian reserve. Inhibin B, if it's less, it is an indication of poor reserve. And AMH, anti-Mullerian hormone, if it is less than 1, again it is a sign of poor ovarian reserve. This is the most important marker nowadays we do to check for ovarian reserve. We can also do an ultrasound where we see the antral follicle count. Anything less than 10 is a sign of poor ovarian reserve. And we don't do this commonly, but just remember clomiphene citrate challenge test is also a test for ovarian reserve. Amongst these, I told you AMH is very important. So AMH, remember, apart from being secreted by the testes in the male embryo, it's also secreted by the granulosa cells of the preantral and small antral follicles. The small follicles, which are 2 to 6 millimeters, secrete, the granulosa cells secrete AMH. Okay, a low AMH is a sign of poor response to ovarian hyperstimulation. It is a sign of low oocyte yield, and also if the patient undergoes IVF, it is related to poor embryo quality also. This is how the antral follicle count is done. You check the right ovary on the scan, the left ovary on the scan, and count how many follicles you see. So I can see 1, 2, 3, 4, 5, 6, 7, 8. Here I can see 1, 2, 3, 4, 5, 6, 7, 8. So 8 in each ovary, 16 follicles, which is a good antral follicle count. Now coming to tests for ovulation. Test for ovulation means, is she having or is she undergoing ovulation? One of the best ways to do this is to take a history. If she's having regular cycles, all the more proven by having, if she has mid-cycle spotting or pain, Mittelschmerz, if she's having painful periods, if she has PMS, these are all signs that she must be ovulating. So then we usually don't go for further tests. But if you have a doubt, then you can ask her to check her basal body temperature. Progesterone is going to increase her temperature by 0.25 to 0.5 degrees Celsius. At the time of ovulation, progesterone increases and her temperature, her basal body temperature will increase. Similarly, cervical mucus study or the Billings method, at ovulation, the cervical mucus consistency changes. It becomes thick and stretchy like raw egg white. This is called as Billings method or cervical mucus study. In fact, BBT and cervical mucus are tests which we actually do also in contraception, family planning, because we want to know when she's ovulating and avoid intercourse at that time. Same thing applies here. This is the time when she will be having intercourse. Now, hormonal studies include day 21 progesterone. I've already told you about this. And we can also check the urinary LH, because we know LH surge will happen just before ovulation. When the LH values are very high in the blood, they reflect in the urinary LH also. Endometrial biopsy pre-menstrual, if it is done, and if it shows secretory endometrium, it is again telling us that yes, ovulation has happened. You can also tell the day of the cycle based on the endometrium that you're visualizing. And if there is a lag of 2-3 days, this means what? Suppose I do the biopsy on day 21. But I find that the endometrium is like a day 18 endometrium or a day 16 endometrium, say. There's a lag of 5 days. That means this could also point to progesterone deficiency or corpus luteal deficiency, which is a cause of infertility and also a cause of recurrent pregnancy losses. So this is how the endometrium appears in the early proliferative phase, the late proliferative phase. As she goes into the secretory phase, the amount of the glands become more and more tortuous and more dilated, and the endometrium becomes thicker and thicker. Ultrasound also tells us which phase of the cycle she could be in. If you see this triple line or trilaminar endometrium, okay, look carefully, you see these 3 lines. This is the endometrium. This is the endometrium, this is the myometrium. So if you see these 3 lines in the endometrium, this is a sign of a proliferative endometrium. So the trilaminar endometrium shows a proliferative phase endometrium, but as this endometrium can you see has become much more thicker, but the trilaminar appearance is still there. So this is just before ovulation because it's so thick. So pre-ovulatory, this is how it's going to look like. And look at this, can you see it's now become uniform or a homogeneous endometrium? It looks the same throughout. That triple line trilaminar appearance has gone. This is a secretory endometrium. So looking at the endometrium also, you know which phase of the cycle she is. So if you see a secretory endometrium, you know ovulation has happened. Another thing we can actually see is the follicular imaging. We see the follicle forming, This is the follicle, this is the antral or the Graafian, mature Graafian follicle. You can see it's very big in size compared to the other smaller ones. Okay, and this is your Graafian follicle. And if you see this big follicle, a dominant follicle, you know that ovulation is going to happen. This ruptures at around 18 to 20 millimeter when this follicle becomes, it's going to undergo ovulation. Another way is by incidentally, if you're doing a laparoscopy for a patient and you're doing it mid-cycle around day 14, you can actually see or you can actually witness the follicle rupturing. So you can see a large follicle, you can see here, and this is just about to rupture. So you can witness, many times we do witness when doing a laparoscopy, you witness ovulation happening right in front of you. Now coming to testing for tubal patency, I told you the first and the initial test is always an HSG. An HSG is a radiological investigation wherein we do it on the 8th, 9th or 10th day of the woman's period. And how is it done? We inject a water or a oil based radio opaque dye in the uterine cavity. How do we inject this? Using this instrument. This commonly comes in the exam. This is a Leach Wilkinson cannula. This can be used to inject the dye, and when we inject the dye, we take the X-ray film and you can see this picture. So the dye will outline the uterus. So if there's any problem inside the uterus, like a space occupying lesion, or if there's a Mullerian anomaly, you can see it, or you can see even the tubes get outlined and you can see whether the spill of the dye in the peritoneal cavity is happening. So this is a normal HSG. That means you can see the uterus being outlined, you can see the tube, the outline of the tube here, and you can see the spill of the dye into the peritoneal cavity. So the initial test we always do is a test for tubal patency. Look at this one here. You can see one tube and spill is seen, but the other side you can't see. This is called a proximal tubal block, also called a cornual block. Look here. Here you can see that the uterus is nicely seen. The tubes are nicely seen, but at the fimbrial end, that is a distal or a fimbrial block is seen. Now, whenever you see such pictures, either a proper HSG is not seen, then we always advise the patient to undergo a laparoscopic chromotubation, because sometimes the HSG may not show the true picture. There may be a tubal spasm at one end. That's why you can't see the dye going out, because it is done under usually local anesthesia or no anesthesia. But in laparoscopic chromotubation, you're actually seeing everything. So it's a confirmatory test. So if the HSG is abnormal, we usually advise a laparoscopy and hysteroscopy to see what is the actual problem. Another test we can do for tubal patency is a sonosalpingography called a SSG. It's also called a saline infusion sonography. It's the same thing. What do we do? It's an ultrasound based test where we inject normal saline, same through a Leach Wilkinson cannula. We inject normal saline, then do the scan and see where the saline is going. Saline will first go and fill up the endometrial cavity. So you can see the endometrial cavity is now black. This black is nothing but fluid, saline, right? Then it will go into the tubes, but we don't see it going in the tubes because the tubes are very, very thin. What do we see? We see the fluid in the pouch of Douglas behind the uterus. So if you see fluid in the pouch of Douglas, you know that at least one fallopian tube is patent. So that's how it indirectly tells us that yes, one tube at least we know is patent. But the best test for tubal patency is a laparoscopic chromotubation. So you're actually doing a laparoscopy and you're injecting the dye. Which dye are we injecting? Can you see the blue dye? The dye which is seen in the pouch of Douglas. This is the pouch of Douglas. This is posterior to the uterus. So the dye you're seeing in the pouch of Douglas here, in this area, this blue color here, this is methylene blue dye. So you've put a laparoscope inside. Somebody from below is injecting the methylene blue through the Leach Wilkinson cannula, and you're actually visualizing the spill from the tube, from the fimbrial end. This is the best way, of course, to see it. It's also the best way because it is a problem, you can tackle it then and there itself. So this is how the dye will appear coming out from the fimbrial end. Now, how do you manage tubal occlusion? If there is a cornual block, so if there's a cornual or a proximal block, the management of choice is to do a hysterolaparoscopy and attempt a recannulation. That means try to recannulate using special instruments done through hysteroscopy, and while looking at laparoscopy from above, try to recannulate the ostia. Distal tubal obstruction is, that is, the fimbria are closed. What can you do here? Here you can attempt a fimbrioplasty, that means try to open up the hole, or do a neosalpingostomy, try to make a new hole at the fimbrial end. But in both of these, you can also offer, in any tubal block, you can offer the patient IVF. Why? Because IVF is going to bypass the tubes completely. There is no job of the fallopian tube in an IVF. So whenever you have a tubal problem, IVF can also be a good option. Okay, but if you're asked proximal tubal occlusion, and this has come twice now in the past, the answer is hysterolaparoscopy, and recannulation is usually the first thing we offer. Then we offer an IVF. If there is hydrosalpinx, that means both the tubes are now filled with fluid and they are not open. What will you do here? Here you will directly advise an IVF, but along with an IVF, you're going to tell them to clip the tube. So bilateral clipping of the fallopian tubes is also advised. You have to do a salpingectomy, that means remove the tubes or clip the tubes at the cornual end, and has been found by doing this, the success rate of IVF goes up. Now, if there's a uterine cause, so we've discussed ovulation problems, ovarian reserve problems, tubal factor, and now how do we diagnose uterine factors like fibroids, polyps, Mullerian anomalies? We diagnose this primarily. A TVS is usually the initial test we get done. Then we have several other tests, including a 3D ultrasound, an MRI, a HSG, a hysteroscopy. Depending on what you're suspecting, you have all these tests available. Now, coming to male infertility, the single most important test in evaluation of male infertility is a semen analysis. This is done after abstinence of 2 to 3 days. We usually say 2 to 7 days absence. It should not be less than 2 days. It should not be more than 7 days. If the sample is collected outside, it should reach the laboratory within 1 hour of ejaculation. And if the initial test is abnormal, what's the next best step? It's not to immediately start treating him. It is to repeat the sample after at least 4 weeks and confirm, because the values can vary on a day-to-day basis. Now, this is important. In 2021, the WHO came out with new values, cutoff values for abnormal parameters in the sperm semen analysis. Sperm concentration is what is important. It used to be 15, now it is less than 16 million, is called as oligospermia. Sperm motility, remember the total motility less than 42% is called as asthenospermia. So less than 42% total motile sperm, if it's there, it's called as asthenospermia. Less than 4% is called as, morphology is called as teratospermia. Okay, and if all three parameters are bad, oligospermia, asthenospermia, teratospermia, it is called as OATS. Okay, so the first test we always do for male infertility is a semen analysis. So normozoospermia is when everything is fine. Oligospermia, as per old definition, was less than 15, now it is less than 16. Azoospermia means no sperm seen in the semen. Aspermia means there is no semen. Asthenospermia means less motility. Now, if you take it's less than 42%. Teratospermia is less than 4%. And OATS means all the parameters are reduced in number. Now, coming to treatment of infertility. How do you treat infertility? The first thing is treatment of anovulation. In anovulation, primarily we are going to do what is called as ovulation induction. What are the drugs used in ovulation induction? Remember these two drugs, very, very important, clomiphene citrate and letrozole. Letrozole, I've already told you, is the drug of choice in polycystic ovarian syndrome. But initially, we used to give a lot of clomiphene citrate. How does clomiphene citrate act? Clomiphene citrate acts because it is an anti-estrogen. So what does it do? It reduces estrogen levels. That's going to build up more and more FSH and LH. This is going to recruit more and more follicles. So you have multiple follicles developing. Okay, and that is going to lead to higher ovulation, of course, and of course a higher chances of having multiple pregnancy also. Twins, triplets, and all are much more common with clomiphene. Okay, so this is going to cause ovulation. Now we give it from day 2 to day 6 is the standard protocol. We start with the lowest dose of 50 milligram per day for 5 days, that is day 2 to day 6, and the maximum dose we can go up till is 150 milligram. 80% of patients who receive clomiphene will ovulate. Okay, they will ovulate in women who are PCOS or having anovulation. If you give clomiphene, 80% will ovulate. The main risk factor, however, is the risk of twin pregnancy or triplet pregnancy, and there is a theoretical risk of ovarian cancer because so many follicles are now rupturing on the surface of the ovary, and this can lead to repeated trauma to the surface of the ovary, and this can eventually lead to ovarian cancer. Okay, but remember that that's why, to limit this risk, we don't give it for more than 6 months. So 6 cycles maximum it is tried. This is a very important thing. Also, because it is an anti-estrogen, what can it do? It can lead to endometrial thinning. So even though ovulation is happening, the endometrium becomes thin and it becomes unfavorable for implantation of the embryo. That's another reason why we don't give it for more than 6 cycles. Now, letrozole is similar in action. It is an aromatase inhibitor, and aromatase is the enzyme that forms estrogen. So, in simple terms, you're again reducing estrogen, again causing FSH to rise, again causing follicular development, but it's not as strong as clomiphene. So it causes monofollicular development. One follicle will develop, so it doesn't cause twins, triplets. Only it causes ovulation and only one follicle will develop. So it's a better drug, and that's why it's the drug of choice. So 2.5 milligram is the starting dose. We again give it from day 2 to day 6. 2.5 milligram per day is what is given. Now, if this fails, we can actually directly use, or in patients who have hypogonadotrophic hypogonadism, we can directly give FSH to stimulate ovulation, or we can give FSH plus LH, which is commonly called as human menopausal gonadotropin. Or you can do in women who have PCOS laparoscopic ovarian drilling. So giving directly gonadotropins or doing a LOD are second line drugs. Okay, second line management options for ovulation reduction in PCOS. This is an image showing laparoscopic ovarian drilling. What is done is that drills are made using a monopolar electrocautery in both the ovaries. So we follow the rule of 4 here. 4 drills are made in each ovary at an energy source of 40 watts to a depth of 4 millimeter, lasting for 4 seconds. Okay, and also remember that what is done is that this is done in each ovary. So in each ovary, you're going to make 4 drills using this rule of 4. The disadvantage of doing this is that because it's an invasive procedure, you may end up damaging more ovarian tissue. Okay, because after all, it's electrical energy. So this may reduce the AMH values. And the second important problem that can happen while you're doing this is that it can lead to adhesions, and that can affect tubal motility. Okay, but these again theoretical risks. You're not that worried, and it definitely will help. 50% of patients who undergo this procedure, they will undergo spontaneous ovulation in the next cycle. Now, if there's a uterine factor problem, you will treat that factor. If it's a polyp, you will do a hysteroscopic polypectomy. If it's a leiomyoma, especially a type 1 or a type 0 fibroid, you can do a hysteroscopic myomectomy. But if it's a larger one or a type 2 onwards, you can do a laparoscopic myomectomy. We'll discuss more about this in fibroids. Asherman syndrome, that is intrauterine adhesions, you'll do hysteroscopic adhesiolysis. And if it's a septate uterus, you'll do a hysteroscopic septoplasty. That means you'll cut the septum hysteroscopically. Tubal factor infertility we've already discussed. And a few important things about assisted reproductive technology. And when we talk about this, we basically mean IVF. So what are the indications of doing an IVF? I've already told you tubal block. Endometriosis is also part of that because it does affect the tubal motility. Male factor, and male factor we prefer to do what is called as ICSI, that is intracytoplasmic sperm injection, what is being showed in this image. Women who have very poor ovarian reserve, AMH is very low, or those who have unexplained infertility. Now, a very important complication which we will discuss of IVF is ovarian hyperstimulation syndrome. But just let's have a look at the other risk factors of undergoing an IVF. There's a higher risk of multiple pregnancy. There's a higher risk of ectopic pregnancy. Heterotopic. What is heterotopic? Is intrauterine plus ectopic pregnancy. Congenital malformations in the fetus. This is plus minus. Okay, some studies do say there's a higher risk, especially of things like hypospadias, but it's not really proven uniformly in all studies. Risk of cancer again is a theoretical risk. That's why that is ovarian cancer. That is why we limit the number of ovulation induction cycles that we give. Then complications in pregnancy like placenta previa can be, multiple pregnancy can be there, and of course the stress associated with undergoing IVF. Amongst these, the question that commonly comes is on OHSS. When you see this picture, these are hyperstimulated ovaries, large bulky ovaries, okay, which are very fragile, and because of this bulk there is extravascular fluid accumulation and intravascular fluid depletion. This is typically seen in OHSS. The primary factor responsible has been found to be HCG, but also there is some role of VEGF, vascular endothelial growth factor, and the main pathologies happening are hemoconcentration and fluid accumulation in the extravascular space. So you have ascites, you have pleural effusion, you have bloating. That is the usual presentation. The risk factor, so young girls with PCOS, normally PCOS are fatter girls, but if you have a thin girls, that is a low BMI PCOS or lean PCOS, young in age with high estradiol levels, is a risk factor for PCOS. Remember, HCG is a culprit. So giving HCG, the woman is again prone to get OHSS. And those who have high AMH, PCOS girls have a high AMH. So that is again a risk factor for OHSS. The patient will present usually following a history of oocyte pickup, okay, or she's undergoing controlled ovarian hyperstimulation in an IVF cycle, and she comes with pain, bloating, abdominal distension, nausea, vomiting, she's breathless, okay, or she's gone to renal failure. There'll be oliguria. This is the usual presentation. It could be mild, moderate, severe, or critical, okay, and you should just know what are the main preventive strategies. So if you have a woman who's at risk of undergoing OHSS, it's important to identify those risk factors. So thin girls with low BMI, with PCOS, with high AMH, with high estradiol levels are at risk. Metformin helps prevent it. Withholding the trigger. What does this mean? So normally we give HCG as a trigger. So if this girl is at risk of developing OHSS, either we don't give the trigger or we change the trigger to GnRH agonist. That is, we give leuprolide as a trigger. Avoid HCG. So whenever you have an option of avoiding HCG, that is a very good option. Avoid HCG as luteal support. Antagonists are better than agonists. So GnRH antagonist protocols are preferred. Albumin helps. Cabergoline, this has come as a question recently. Cabergoline helps in several places in obs and gynae. It is used in endometriosis. Okay, it is used in OHSS prevention, and it is also used primarily in hyperprolactinemia. Coasting means withholding the gonadotropins. You can cancel the cycle, or you can cryopreserve the embryos and not proceed further with the IVF cycle. How do you manage this? If she's mild and moderate OHSS, you can manage in the OPD, but for severe and critical, you have to admit. And the mainstay of management is fluid management and maintaining electrolyte balance. That is the mainstay of management of ovarian hyperstimulation syndrome. So now we begin with fibroids. Fibroids are a part of benign gynae disorders. In benign gynae disorders, it's important to revise three important things. One is fibroids, one is endometriosis, one is adenomyosis. Questions come from all three. It's important to understand how they present, their clinical presentation. Few important high things about all of them we will discuss. Starting with fibroids. So what are fibroids? They are benign tumors of the uterus. They are the most common benign tumor of the uterus is a fibroid. Okay, and when it comes to fibroid, it's important to understand the basic classification. So this is the uterus. You can have a submucosal fibroid, you can have an intramural fibroid, or you can have a subserous fibroid on the outer surface of the uterus. But this is the older classification, and the newer classification is this one. And just to take you through it quickly, this is basically the FIGO classification. Never been asked, but always a potential question which can come. The FIGO classification classifies fibroids as two basic types, submucosal and others. Okay, and then it further divides, it gives different numbering system to each of them. So we'll just quickly draw it, and I suggest you draw it with me for a quick revision. So this is a type 0 fibroid, that is a pedunculated submucosal fibroid. This one is a type 0 fibroid, a pedunculated submucosal fibroid. This is a type 1 fibroid where more than 50% is submucosal, less than 50% is intramural. This is a type 2 fibroid where more than 50% is intramural, less than 50% is submucosal. So types 0, 1 and 2 are submucosal fibroids. And in this, remember, very importantly to remember, type 0 and type 1 can be removed hysteroscopically. You can do a hysteroscopic removal. Then you come to the other ones. Then you have a type 3 fibroid, which is just touching the endometrium. Otherwise, it is an intramural fibroid. A completely intramural fibroid is type 4. More than 50% intramural, less than 50% subserous is type 5. More than 50% subserous, less than 50% intramural is type 6. And a pedunculated subserous is type 7. Okay, and then another type is type 8, which could be a cervical or a broad ligament. That means unusual location of fibroid becomes a type 8 fibroid. So you have type 0, 1, 2, which are submucosal, then 3, 4, 5, 6, 7, 8, which are others. Okay, and then you have another type called the hybrid fibroid. Hybrid is which is encompassing all three areas. That is starting from submucosal, intramural, subserous. It has such large fibroids many times we see which have all three components. So quick revision of this, it's important to know this classification. It can come anytime in your exam. Now, degenerations are very important. So in fibroids, we have red degeneration, but this is not the most common. The most common type of degeneration is actually the hyaline degeneration. Red degeneration is important because it's something which is very unique in Obs and Gynae, and it is typically seen in pregnancy. So a pregnant woman, if the question comes, a pregnant woman with acute abdominal pain, with a known case, especially someone with a known case of having a fibroid, especially in the second trimester, fever may be there, leukocytosis will help you reach at a diagnosis. So this would point towards red degeneration of the fibroid. Okay, so red degeneration is, it looks like this, although you will never do surgery for a red degeneration, never do surgery, always managed conservatively. No matter how much pain the patient is, it will eventually settle with analgesics and with hydration and with rest. So this is what you should know about red degeneration. Also, it can happen, it can occur even in the puerperal period, and even in women taking on oral contraceptive pills, it can happen. Okay. Now, how does a fibroid present? A fibroid, this is the presentation in pregnancy. Otherwise, majority of them are asymptomatic, and if they're asymptomatic, how do you treat them? Nothing needs to be done. So no treatment for an asymptomatic fibroid. Okay, even if they are very, very big in size, they don't need treatment. They can cause menstrual abnormalities. Menstrual abnormalities, and the most common one we talk about is menorrhagia, which is now called as heavy menstrual bleeding. That means bleeding which is excessive in amount or duration, but the cycle is regular. So regular cycle with excessive bleeding, either in duration or in amount, is menorrhagia. And this is the most common symptom of a fibroid. Why does it happen? Because of increased vascularity. There could be endometrial hyperplasia. Okay, there could be, there's dysrhythmic uterine contraction, so the bleeding doesn't stop, and there could even be coincidental endometrial cancer. Because remember, fibroids are a hyperestrogenic state. Okay, and what are the other things which are hyperestrogenic? One is fibroids, Endometriosis is also a hyperestrogenic state. Then endometrial hyperplasia and endometrial cancer. These are all hyperestrogenic states. They will grow when there is estrogen. Another common complaint is secondary or congestive dysmenorrhea. This is the dysmenorrhea which may start before her periods, may last through her periods, may last even beyond her periods. Unlike spasmodic dysmenorrhea, which is primary dysmenorrhea, which disappears a few hours after the onset of the period. So, congestive dysmenorrhea is usually because of an etiology. It's secondary to fibroids, secondary to adenomyosis, secondary to endometriosis. Primary or spasmodic dysmenorrhea is a dysmenorrhea which is most the physiological kind of dysmenorrhea, which is seen very commonly in girls and women and disappears a few hours after the onset of the period. Now, infertility is again a common symptom. Okay, but which kinds of fibroids do you think will cause infertility? All submucosal fibroids, if a woman comes with infertility and she has a submucosal fibroids, these need to be removed. So, in other words, in which patients will you do a myomectomy for if she has a fibroid and she has infertility? So, myomectomy in infertility or subfertility is indicated for number one, all submucosal fibroids, because they are sitting in the endometrial cavity. They are most likely they are going to disturb implantation. It's better to remove them if the woman has come with infertility. Second is all large intramural fibroids, which are either very large in size, that by very large I mean more than 5 centimeters, or those that are distorting the endometrial cavity. They need to be removed. So, all submucosal fibroids and all large intramural fibroids, either more than 5 centimeters or large, so large that they are distorting the endometrial cavity. For these two categories, you're going to do a myomectomy if she has infertility. This is very important. They may cause abdominal mass. They may present as an abdominal mass, pressure symptoms. If it's a posterior fibroid, they usually present with rectal symptoms or bowel symptoms, and constipation is a common complaint. If it's an anterior fibroid, they usually present with retention of urine or frequency of urine because they keep pressing on the urinary bladder. Pregnancy and fibroids. So, what happens to fibroid and pregnancy? It undergoes regeneration. What happens to pregnancy because of fibroid? First of all, it can cause recurrent pregnancy losses, abortions in any trimester, first trimester, second trimester, recurrent pregnancy losses. It can cause fetal growth restriction. It can cause placenta previa, even abruptio placenta is more common. So, APH in general is more common in women who have fibroids. It can cause malpresentations. Okay, it can cause prolonged labor or inadequate contractions during labor. It can even lead to cause an obstructed labor if there's a large fibroid in the way of the baby coming out. It can lead to postpartum hemorrhage, especially atonic postpartum hemorrhage. It can even lead to retained placenta. So, starting from the first trimester right till puerperium, these are the problems that can happen with a fibroid in pregnancy. Investigation of choice is what is this? What is this? This is an ultrasound. Ultrasound is the investigation of choice. You see well circumscribed lesions inside the uterus. You can also get an MRI done if you're doubtful, but the ultrasound is the investigation of choice. We do not need to treat asymptomatic fibroids even if they are very big in size. Remember this. Symptomatic fibroids, however, you can manage them medically, surgically, and there are some newer techniques. Remember, 2 uterine artery embolization and MR focused ultrasound waves. These can also be used, but primarily we have medical and surgical management. But which management do you prefer? Depends on several things. Depends on her symptoms. Okay, I add here also depends on the symptoms, the age, the severity, the size, and the location. And I've already told you, if it's fibroids and infertility, what will you do? You'll remove the ones that are submucosal and you'll remove large intramural and those distorting the cavity. So, if you have a patient, the question comes, subserous fibroid and she has infertility. Do you need to remove it? No, a subserous fibroid sitting here is not going to affect fertility. Okay, because the implantation is happening here. So, only something which is affecting the endometrium is going to need to be removed. Now, what are the medical management options we have? Okay, so this is an important table. I'll tell you what you need to know in this table. Remember, the drug of choice is usually an NSAID or an NSAID. So just add NSAIDs here. NSAIDs plus tranexamic acid is the drug of choice. Or if we have to choose amongst both, depends on the symptom. If the primary complaint is dysmenorrhea, even in menorrhagia, NSAID is your first option. Otherwise, a combination of NSAID and tranexamic acid, which is an antifibrinolytic, this would be a second option. This will reduce the bleeding. TXA, tranexamic acid, will reduce the bleeding. Meftelspaz or NSAIDs will reduce the pain also. Okay, so remember, it is symptomatic only. Okay, what I'm telling you is important. What I'm not mentioning is not important in the table. Second is mifepristone and ulipristal. Now, both of these are SPRMs. Okay, what is SPRM? Selective progesterone receptor modulator. Mifepristone is actually an SPRM with more of anti-progesterone kind of action, but it's an SPRM. Okay, it reduces, both of them will reduce the size and bleeding, and it's usually, both are usually given over 3 months. Now, what is important to take home message from here is this one. Ulipristal acetate, which is, where else is ulipristal acetate used? It's also used as an emergency contraception. Ulipristal, remember, is hepatotoxic. It affects the liver, and it was even withdrawn by the FDA in between, but then reintroduced with a warning that it can cause liver toxicity. So that's important to remember. Then GnRH agonists, they reduce the size and bleeding also. But if you're using them for long term, what happens with GnRH agonists? It leads to a state of pseudomenopause. So these women become hypoestrogenic, and that can affect the bone density and lead to early onset osteoporosis. So to prevent that, you have to add back therapy to prevent bone loss. Usually we give Tibolone, okay, supplement Tibolone, and this will prevent bone loss. So with GnRH agonist long term, think of add back therapy to prevent bone loss. Combined oral contraceptive pills can also be given, but they are again symptomatic. They will not reduce the size of the fibroid. Danazol is a drug which used to be used long back, many decades earlier. It was one of the best drugs that was given, but it was also given in endometriosis very commonly. But remember, it causes a lot of androgenic side effects. And because of the androgenic side effects, it went into disrepute, and now it is hardly available in the market also. LNG IUD is the Mirena. Mirena is a very good option. Mirena is a contraceptive progesterone containing intrauterine device, but it has a lot of non-contraceptive benefits, because whenever you're giving progesterone, it acts by causing endometrial atrophy, and that is what will reduce the bleeding. Okay, and it also is known to reduce the size of these fibroids. So you give it you insert the intrauterine device, and this will slowly shrink the uterus in size and the fibroids in size. But remember that this is 5 to 8 years. Earlier it was approved for 5 years. Now it is approved for 8 years for use for contraception. Okay, and remember, it can be put in fibroids, but not in fibroids that are distorting the uterine cavity. So contraindicated in fibroids that are distorting the cavity, because you can't put an intrauterine device if the cavity is distorted. Surgical options, what do we have for fibroids? We have myomectomy. That means this is the uterus, you have a fibroid, you're just removing the fibroid, nothing else. Okay, or you remove the entire uterus, what is called a hysterectomy, and that depends, of course, on the age of the patient. The patient is young, wanting fertility, okay, not getting resolved by medical management, or say she has infertility in a large 8 centimeters intramural fibroid, what will you do? You will do a myomectomy, and a myomectomy can be done laparoscopically or by laparotomy, that is abdominally, and you can also do it hysteroscopically, that means putting in a scope inside the uterus. This is for type 0 and type 1 fibroids. Okay, now some images which you should know from the topic of fibroids. This is a Bonnie's myomectomy clamp. Remember, fibroid surgery, myomectomy, is a very bloody surgery. So there are a lot of things we do intra-op to reduce the incidence of blood loss. One of them being clamping the uterine arteries here using this device. And this is used to temporarily occlude. So for 20 minutes we apply, then we remove it, because we don't want to cause uterine ischemia also. So while this clamp is in place, quickly do your myomectomy and then release it. Okay, so that the uterus regains its blood supply. Then again clamp, then again do your surgery. So this reduces the amount of blood loss. This is another important instrument you should know. This is a myoma screw. So it is used to give traction while you are enucleating the fibroid in laparotomy. What is this image showing? This is an image showing a large central cervical fibroid. And this typical image of a small uterus on a large fibroid is called a lantern on St. Paul's Cathedral. So if you get this question, a lantern on top of St. Paul's Cathedral is used to describe what? It is used to describe a cervical fibroid. Now coming to endometriosis. Endometriosis, remember, is what is it? It is endometriotic implants outside the uterus. Okay, so you have endometriotic implants outside the uterus. So you have the uterus here. Okay, and the endometrium, which is here, you find these implants in the peritoneal cavity, and most common site you find them is in the ovary, where they grow. So whenever the woman gets her period, this endometrium will bleed. Also, this endometrium also bleeds and forms what is called, especially in the ovary, is going to form a chocolate cyst. It also bleeds wherever the implants are there, they will bleed, and everything gets stuck to that area. So the ovaries get stuck behind the uterus. They're called as kissing ovaries. The tubes get stuck, and that affects tubal motility, leading to infertility. So everything gets stuck. So there are a lot of adhesions seen. There are a lot of adhesions seen with endometriosis. Okay, and that's why it affects the tubal motility, leading to infertility. Okay, and a typical presentation is the chocolate cyst or an endometrioma, right? Now, how do this endometriosis, and one of the main theories you should know behind formation of endometriosis is retrograde menstruation. There are many theories, but one important one is the theory of retrograde menstruation, which says what? That the blood goes backwards. That means instead of the period going down, which it will, some blood seeps back inside the tubes into the peritoneal cavity. And if there is an obstructive Mullerian anomaly, we've discussed this, it is an obstruction here, that is going to lead to endometriosis. So, which obstructive Mullerian anomalies will lead to endometriosis? An imperforate hymen, a transverse vaginal septum, and Ovira syndrome, if you remember, in uterine didelphys, obstructed hemivagina with ipsilateral renal anomaly. What else? You'll have cervical agenesis, there's no cervix. Vaginal agenesis, there is no vagina. Then a uniconnuate uterus with a rudimentary horn, which is non-communicating, will also lead to endometriosis. So that's important to remember. Some Mullerian anomalies can cause endometriosis. Which ones? The ones which are obstructive. Now symptoms, remember, in symptoms, very easy to remember, the 5 Ds. What is the first D? Dysmenorrhea, which is progressive, and it is triple. That means premenstrual, menstrual, and postmenstrual dysmenorrhea. Then you have dyspareunia, which is painful intercourse, especially deep dyspareunia. This is because of rectovaginal endometriosis. Similarly, dysgeusia, painful defecation, is again because of rectovaginal endometriosis. That means endometriotic implants behind the uterus, between the uterus and the rectum in the pouch of Douglas. So you have dysmenorrhea, dyspareunia, dysgeusia, then dull, aching, abdominal pain, and the last D is dysfertility. It should be infertility, just to make it a D, it is dysfertility. Okay. Remember, here you are not seeing one important common complaint a woman comes with is AUB. So abnormal uterine bleeding is not usually seen in endometriosis. It's an unusual presentation. Okay. The more common presentations are the 5 Ds. Okay. What are the signs? A common clinical question they'll give you the signs. They'll give you on examination, this is found. So what will you find? You'll find, remember, these are the buzzwords to remember. You find a retroverted fixed uterus, with nodularity in the pouch of Douglas. These are your buzzwords. If you see this, you know that this is most likely endometriosis. What do you see if you do an ultrasound? So, an ultrasound is, of course, not the best investigation. The best investigation is actually a laparoscopy, is the gold standard, is the best investigation to diagnose endometriosis. But a good investigation is an ultrasound. An ultrasound, especially if you're suspecting a chocolate cyst, this is how it looks like. This has come as a question several times. This is how an endometrioma or a chocolate cyst will look like. This grey-white appearance is called as a stippled appearance, and this is typically seen in a ovarian cyst or with old blood as the contents. That is a chocolate cyst. An MRI would be the best non-invasive diagnostic tool, but if you just ask the best diagnosis, the best investigation, okay, if they don't ask invasive, non-invasive, and this is standard, laparoscopy is the gold standard. It is the rule. It should be done, especially if you're strongly suspecting endometriosis. Laparoscopy is the best way to diagnose it. Okay, now how do you treat endometriosis? So endometriosis, remember, the basic mantra is there are two symptoms, right? Pain and infertility. If pain is the primary symptom, we usually try medical management first. But if infertility is the primary symptom, then surgical management would be better, because you want to see the anatomy, you want to see the tubes, you want to try and restore normal anatomy, you want to take out any chocolate cysts, you want to ablate any endometriotic deposits, you want to do adhesiolysis and try to restore normal anatomy as far as possible. So this is the mantra. If the question says pain is the primary symptom, then think of managing her medically. But it depends on a lot of other things also. What is medical management? Again, initially we start with NSAIDs. We can even give combined contraceptive pills, and this is usually given continuous, not cyclical. We give it continuous, so the woman is in a state of amenorrhea, and that leads to healing of the endometriotic implants. Or you can give progesterone in many forms. You can give it oral, you can give it injectable, and you can even give it as an intrauterine device, that is the Mirena. Progesterones act by causing endometrial atrophy. So wherever there are these endometriotic implants, they will get dried up. We can even give GnRH agonist, because this leads to a state of pseudomenopause and the endometriosis will dry up. So this is medical management. Surgical management, I told you, is preferred. If there's a large chocolate cyst, then you will do surgical management. Like in this picture, what will you do for a large chocolate cyst? For a large chocolate cyst, you will do a laparoscopic ovarian cystectomy. Okay. And apart from doing a cystectomy, the other smaller deposits you can ablate. Ablate means burn them or excise them, remove them, or do an adhesiolysis. That means cut up the adhesions. Or you can do LUNA. What is LUNA? LUNA is laparoscopic uterosacral nerve ablation. What is this? This is done in patients who have pain with endometriosis not responding to medical management. Then you can think of LUNA, where the main nerve plexus in the uterosacral ligaments are ablated, okay, and that leads to reduction in pain. If nothing else is working, then hysterectomy, of course, but this is done rarely, only if nothing else is working. So that's about endometriosis. And a much shorter topic, adenomyosis. What is adenomyosis? Adenomyosis is when there is globular enlargement of the uterus. Why? Because of endometriotic implants in the myometrium. So in endometriosis, you have endometriotic implants outside the uterus. In adenomyosis, you have endometriotic implants within the uterus in the myometrium. Now, the typical presentation of an adenomyotic woman would be a Paris woman. Remember, fibroids and endometriosis are commonly associated with low parity or nulliparity. They will not have kids. Okay, but adenomyosis is common in a Paris woman in the age group of 40, between the age group of 40 to 50 is the most common age group. Of course, it could be a little lesser, a little higher, but this is the common presentation. And she will present with menorrhagia, and dysmenorrhea. These are the two symptoms of adenomyosis, menorrhagia and dysmenorrhea. How will you diagnose it? You will diagnose it by ultrasound. Ultrasound is the investigation of choice. And how will you manage it? Management, the definitive management is hysterectomy. So doing a hysterectomy is the definitive. Of course, you can give a symptomatic management for controlling the menorrhagia and the dysmenorrhea. So adenomyosis, this is how an adenomyotic uterus will look like. It is called typically as a globular enlargement of the uterus, and this is a regular enlargement. Remember, a fibroid, especially if she has multiple fibroids will cause irregular enlargement. Adenomyosis will cause regular enlargement. Okay, so what happens? You have endometriotic deposits inside the myometrium. That's what's happening. Okay, and what are the risk factors? You have women who are parous, okay, whose parity is higher, not nulliparous. Age, I told you, in the age group of 40 to 50 years, okay, and there are some associations, but not very important to know these. Clinical features, symptoms, I told you, menorrhagia and dysmenorrhea is what usually happens, and signs is important. So you have regular uterine enlargement, and remember, unlike fibroids, the uterus will not be more than 12 to 14 week size. That means it doesn't become a very big uterus. Very rarely you will find big size uterus. Maximum size would be 14 weeks size uterus. So in fibroids, however, you can have huge sizes of uteruses, even going up till 30 to 36 weeks of a pregnant uterus. They can even reach that size. So that's a major difference. So parous woman in the age group of 40 to 50 with menorrhagia and dysmenorrhea with a regularly enlarged uterus is adenomyosis. You will diagnose this by ultrasound, where you see different features. Again, never been asked, but just remember that the investigation of choice, this has been asked, of course, is an ultrasound. Okay. And in ultrasound, the more specific answer would be a transvaginal sonography. Management, I told you, is medical, or is definitive management is surgical, removing the uterus. Medical management is only for symptomatic treatment. You can treat her pain with NSAIDs. You can treat her bleeding with tranexamic acid. You can put her on combined contraceptive pills, which will reduce both the pain and bleeding. You can put in a Mirena or give her oral or injectable progesterones, which will cause endometrial atrophy. And as I said, you can put in a Mirena, or you can give her GnRH agonists. But the definitive management is going to be a hysterectomy. Okay. Now coming to an important topic, that is abnormal uterine bleeding. In abnormal uterine bleeding, remember that the definitions have changed. There used to be an earlier definition, okay, where the normal length of the cycle was taken as 21 to 35 days. The average length, of course, being 28 days, and plus minus 7 days was taken as the range. And normal duration was counted as 2 to 7 days with the average 30 ml of blood loss in every cycle. So this was the earlier definition of a normal menstrual cycle, but now we have new definitions, and in new definitions, and this is important because it's being now asked in the exams, so it's important to know these. Now the new definitions are that the frequency is now between 24 to 38 days. Anything less than 24 days is now called a frequent cycle, what we used to call polymenorrhea. Now it's called a frequent cycle. Anything more than 38 days is an infrequent cycle, what we used to call oligomenorrhea. Now it is infrequent. Okay, so that's the first important change. The second important change is that the lower limit of bleeding has been removed and the upper limit has been increased to 8 days. It used to be 2 to 7 days. Now it is less than or equal to 8 days. Now regularity is something which is different. Regular cycle does not mean, we used to say regular cycle means 21 to 35 days. That is a normal frequency. Regularity, the definition means if you take in the last 6 months, if you ask the patient to show her menstrual calendar, and if you take the shortest cycle length and the longest cycle length, if it is less than or equal to 7 to 9 days, the variation between the shortest cycle to the longest cycle is less than 7 to 9 days, then it is a regular cycle. That means, say 1 month she has a 24-day cycle, then she has a 36-day cycle, then she has a 29-day cycle, then she has a 25-day cycle. So if you see the shortest and the longest, this is a difference of 12 days. Although maybe it may be of normal frequency, because it's coming between 24 to 38 days, but it is still irregular. So that's another important concept. And flow volume, what you can't actually measure the amount of blood loss, right? So this is patient determined. If the patient says I am bleeding heavy, she's bleeding heavy. If the patient says I am bleeding less, she's bleeding less. So this is now patient determined. These were the earlier definitions, and why they are still important to know is because in your clinical questions, when the examiner makes the question, we are still, even if I am supposed to make a question, I will very commonly use these terms because they've been used since so long, it becomes difficult to forget them so easily. So menorrhagia, I told you this before, is a regular cycle bleeding which is either excessive in amount or duration. The opposite of menorrhagia is hypomenorrhea, that means scanty bleeding. Similarly, polymenorrhea is a frequent cycle, oligomenorrhea is an infrequent cycle. Metrorrhagia is irregular bleeding in between the cycles. You have a woman who's having her regular periods and in between she's having bleeding, intermenstrual bleeding. And if that intermenstrual bleeding is excessive, it is called as menometrorrhagia. So excessive intermenstrual bleeding is menometrorrhagia. So this is the new FIGO classification. So if you look at the ones in white are the normal ones. So frequency normal is 24 to 38 days. Duration normal is up to 8 days. Regularity, the shortest to longest should be less than or equal to 9 days. Flow volume normal is patient determined. Okay, no intermenstrual bleeding should be there. And there's a new thing which has been added, that is unscheduled bleeding on hormonal medications. So if the woman is taking some hormones, say commonly we give for contraception, if she's bleeding on that, then you have a separate category for that also. Now, what are the causes of AUB? And remember the PALM Cohen, very important. PALM refers to the structural causes and Cohen refers to the non-structural causes. So what is PALM in the structural? P is for polyp, endometrial or a cervical polyp. A is adenomyosis, which we have discussed. L, we have discussed leiomyoma, which could be submucosal or other. And M is malignancy, and hyperplasia is also here. Hyperplasia is endometrial hyperplasia, which is a pre-malignant condition for endometrial cancer. So that has been kept here. So polyp, adenomyosis, leiomyoma and malignancy. And Cohen is a non-structural. C is coagulopathy, say she has von Willebrand's disease or ITP. O is ovulatory. So here you have PCOS or luteal phase defect or something to do with the ovulatory problem. Endometrial refers to an endometritis. Okay, or maybe an infection in the endometrium or genital tuberculosis causing endometritis, causing hypomenorrhea. That would be endometrial cause. Iatrogenic is because of some drug, say she's on warfarin, or you've put in a copper IUCD and she's having heavy bleeding. That is iatrogenic. And N is not yet classified. There are some causes where you can't fit in anywhere. For example, if she has, and very commonly we see nowadays, a uterine arteriovenous malformation. You can't fit this anywhere, so you put this under not yet classified. Now, a common question which comes is related to, because now clinical questions come, and clinical questions, they will give you a scenario of AUB. One of the important things when you get a question AUB is always look at the age of the patient mentioned. If she's in the adolescence, certain things are more common in certain age groups, right? If she's in the adolescence, you think of anovulation. Anovulation commonly causes puberty, menorrhagia. So commonest cause of AUB in the adolescent period is an anovular cycle. Other than that, it may be contraceptive related. Okay, many women, maybe not in our country, but in the West, many girls are on contraception. It could be related to that. It could even be related to pregnancy. So I'm not ruling out pregnancy. I will put it a bit lower down in the list. It's not something you will commonly think of in this age group. Then a coagulopathy, a tumor, rare tumors can happen, but this is the order in which you will start thinking of. Similarly, in the reproductive age group, in the age group of 19 to 39, if a question comes that a woman is having irregular bleeding, she's 25 years old, even if she's unmarried, I will get a pregnancy test done because my main worry is now pregnancy related problem. Or it could be if pregnancy is not there, think of the things we just discussed: benign disorders, fibroids, polyps, adenomyosis, endometriosis, all that will come here. Although endometriosis, I told you, doesn't commonly cause AUB, but think of a structural lesion. Anovulatory comes lower on the list. Contraception also comes somewhere in the middle part of the list. Hyperplasia and cancers are again there, but you will think of them lower down in the list. However, in the perimenopausal age group, you will think of hyperplasias and cancers higher up in the list. Okay, and structural causes lower down. So anovulation again common in extremes of age. So adolescence and perimenopausal anovulatory bleeding is very common. Perimenopausal, you now start thinking of cancers and precancerous lesions. Okay, in the postmenopausal age group, you will think of endometrial atrophy also, and structural causes, fibroids, polyps, adenomyosis, these come down lower down in the list, okay, compared to the reproductive age group. Now, a common topic which is very commonly asked is endometrial hyperplasia. And this topic, if you look in your RR notes, you'll find this along with endometrial cancer in the gynae onco part. So skip a few pages and then you will find this. The endometrial hyperplasia, what is this? Remember, it's a histopathological diagnosis. It is not a clinical diagnosis. Of course, in clinical, it is a clinical suspicion, but it's diagnosed only on endometrial biopsy. So there is endometrial thickening with proliferation of the endometrial glands. Okay, and that is what is happening here. The endometrium becomes thickened. That's what we see on the ultrasound, but we can confirm this only by a biopsy. Now, why does this happen? Remember, I told you it is a hyperestrogenic state. So, women who are having more estrogen in the body is the single most important cause. And primarily, we have two types of hyperplasia. So, if you look at the pathological classification of endometrial hyperplasia, this is the older classification. You have simple hyperplasia without atypia, and we have complex hyperplasia without atypia. So when atypia is not there, you're not that worried because the risk of malignancy is on the lesser side. But if there is atypia, so look here, simple hyperplasia with atypia, complex with atypia, you have a much higher risk of malignancy. That's why in these two groups, you can manage them with medication. What medication do we give? You want to dry up the endometrium, you're going to give progesterone. But in these two, you're worried about cancer. So what will you do here? In these two, you're going to do a hysterectomy. I told you this is the older classification. What is the newer classification? Is much simpler. We just say endometrial hyperplasia without atypia and endometrial hyperplasia with atypia. So you've clubbed these two together. And you've clubbed these two together. So it's much simpler now. You club these two together without atypia, endometrial hyperplasia without atypia, and endometrial hyperplasia with atypia. Without atypia, you're going to give progesterones. With atypia, you're going to do surgery. That is, you're going to do a hysterectomy. But how does such a patient present? How will the clinical question come in the exam? Again, you'll have a woman between the age of 40 to 50 with usually an abnormal uterine bleeding pattern. And the common pattern you have is periods of anovulation. That means she'll have 2, 3, 4 missed cycles and followed by heavy bleeding. This is the typical presentation of endometrial hyperplasia. And when you examine her, you will find all normal findings. The uterus will be normal in size. There will not be any enlargement of the uterus. And the adnexa, that means the ovaries, will feel absolutely normal. So it will be completely normal examination findings. So, and these women are again usually nulliparous or low parity. So the question will be a 45-year-old nulliparous lady presents with heavy bleeding on and off since 4 months. When you examine her, you find the uterus is normal in size. What is the next best step? The next best step is to do an ultrasound. Okay, remember this. And if you don't have ultrasound in the options, the next best step would be to take an endometrial biopsy. Okay, usually we go in order. We first will do a ultrasound, but it's not necessary. You can also directly do an endometrial biopsy. But if the ultrasound is mentioned in the options, this would be a better option to mark. Otherwise, you can directly also proceed to do an endometrial biopsy. So this is the uterus on TVS, transvaginal scan. This is a normal uterus, okay, with a normal myometrium and a normal endometrium. Look here, can you see how thickened the endometrium has become? So this is a thick endometrium, okay, and in the reproductive age group, we take an endometrium more than 15 millimeters as abnormal. That it means it needs to be biopsied. Okay, and look here, can you see these black spaces are cystic spaces in the endometrium? Again, is not a good sign. It's better to take a biopsy from these cystic spaces. So how do you take a biopsy? You can either do a dilatation and curettage. But because you're doing a dilatation, okay, it is usually a painful procedure, so it may require some form of anesthesia. Endometrial aspiration is an OPD procedure, or an endometrial biopsy, office endometrial biopsy it's called as. It's an OPD procedure with thin plastic cannula called the Vibra aspirator or an endometrial sampler are used to take out a biopsy. And the gold standard is, however, is to actually look inside the uterus, see the uterus with a hysteroscope, look at the abnormal area and take biopsy from there, because these two are blind procedures. So you may miss an important area when you're doing the curettage or when you're taking the office biopsy. So looking and taking a biopsy is of course always better, and this comes as a question. So hysteroscopic biopsy is the best way to take a biopsy. And I've discussed this already. Once you've got the histopathology report of endometrial hyperplasia, see whether there is atypia or there is no atypia. If there is no atypia, you don't have to be worried now. You can put her on cyclical progesterones, or better than COCs would be just cyclical oral progesterones or Mirena. Remember these two. Progesterone is what you should do, and continue taking office biopsies every 3 to 6 months till it has completely resolved. But if shit has come as atypical hyperplasia, then what do? Then we do a hysterectomy. Okay, with a bilateral salpingo oophorectomy, remove the ovaries also, because in atypia there is almost a 30% risk of this woman developing endometrial cancer. Now, along with this comes the topic of postmenopausal bleeding. Again, a very commonly asked scenario in the exam. So, when a woman comes with postmenopausal bleeding, there could be multiple causes, okay, as shown here. But you should know that the most common cause is what? The most common cause is going to be a senile endometritis. This is the most common cause. That means a dry endometrium, a very thin endometrium, and atrophic endometrium is going to bleed, can bleed if it's very thin. But we are when a patient comes with postmenopausal bleeding, we are very worried. Why? Because you don't want to be missing this or this. That means a cervical or an endometrial cancer. Amongst both, of course, cervical cancer is more common, but you don't want to be missing this. And that's why it becomes very important to evaluate this patient in detail. So the most common cause is an atrophic endometrium, but cancers need to be ruled out. Okay, so the main aim is exclude malignancy. So how do we do that? If a patient comes with postmenopausal bleeding, the first thing we do is we of course examine her. We put in a speculum and look at the cervix. If there's a cervical growth, we know this is the cause of bleeding, and you take a biopsy. Okay, take a punch biopsy from a cervical growth. But if the cervix looks normal, the next best step is to do a transvaginal scan and look at the endometrial thickness. Okay, so you're going to look the endometrial thickness. You'll of course look at other things also, but primarily I'm worried about this. It should not be thick. If it is 5 millimeter or more, I am going to take a biopsy, because this is not normal. In the postmenopausal age group, the endometrium should be less than or equal to 4 millimeter. Anything more than 5 makes me suspicious for cancer. So I will do a hysteroscopy. Ideally, the best way again to take a biopsy is to do a hysteroscope and take a biopsy. You can also do a DNC or an office biopsy, but the best way, where you don't want to miss out anything, is a hysteroscopic guided endometrial biopsy. Okay, so this is the flowchart for the same. Postmenopausal bleeding, woman has come, do a history examination. If there's a growth on the cervix, take a biopsy. If there's no growth, if the cervix looks normal, remember, yes, you will take a pap smear and a TVS, but which is in the exam, both are asked, what will you say? The better answer is to do a TVS, because if there's no growth, you have in a way ruled out cervical cancer. Pap smear we are taking because it is part of routine checkup, right? You want to still screen her for cervical cancer. But we are at this moment more worried about what's inside the uterus. So TVS is a more appropriate answer. And in this, look at the endometrial thickness. If it's less than or equal to 4 millimeter, you're not worried. But if she has repeated episodes of bleeding, again, better to take a biopsy, an endometrial biopsy. And if it's 5 or more, then definitely you're going to take an endometrial biopsy. Okay, so we will continue now with a very important topic, that is contraception. So now we come to a very important, very high topic, that is contraception. And there are a lot of changes which have happened in recent times regarding contraception, especially in our country. Okay. So we start now with, of course, this is a PSM topic also. So a lot of it will be covered under PCM or PSM also. But we'll quickly revise the important things. Now, what is Pearl Index? Pearl Index is a measure of efficacy of a contraceptive method. What is the formula? It is a number of accidental pregnancies divided by the total months of exposure that couple has towards that contraceptive method and multiplied by 1200. So, just to repeat, Pearl Index is the number of accidental pregnancies divided by the total number of months of exposure to that contraceptive method and multiplied by 1200. So that is the Pearl Index. If the Pearl Index is less than 1, it is usually said to be an effective method. Another important thing which you should know is this wheel. This is the WHO MEC wheel, Medical Eligibility Criteria wheel for contraceptive use. What is this? This tells us the MEC criteria, and this is divided into 1, 2, 3 and 4 for different contraceptive methods in different medical conditions. What are the contraceptive methods so there are 6 contraceptive methods which have been described in this wheel. If you look here, you have the copper IUCD, you have the LNG IUCD, you have the implants, the progesterone implants, you have the injectable progesterone, you have the progesterone only pills, and you have the combined contraceptive methods, the ring, the patch, the pill, or combined OC pill, the estrogen plus progesterone combined methods. So just to repeat, what are the contraceptive methods explained here? You have the combined estrogen plus progesterone methods, you have the progesterone only pill, you have the injectables, progesterone only injectable, you have the progesterone implant, you have the progesterone intrauterine device, and you have the copper intrauterine device. These are the 6 contraceptive methods described under the WHO wheel, and for every medical condition a number is given, that is 1, 2, 3, 4. 1, if it's given, 1 means the method is absolutely safe for use for that contraceptive method in that medical condition. 2 is that the benefits outweigh the risks. That means in both 1 and 2, this method should be used. Okay. Whereas 3 is when the risks outweigh the benefits. That means it is relatively contraindicated. That method is relatively contraindicated for that medical condition. And 4 is when it is absolutely contraindicated. You should not be using it. For example, oral contraceptive pills in a woman with a history of DVT is MEC4. You're not going to use it. Okay. Whereas an 18-year-old girl with no medical conditions comes for using the contraceptive pill, she's MEC1. Okay. So that's how you know what to use and what not to use, by using this medical eligibility criteria wheel. Now, the government of India very recently in the last year came out with its own MEC wheel, which is green in color. Can you see the WHO one is blue in color? The government of India wheel is green in color, and it has 7 contraceptive methods. You have the same 6 ones plus another one. The plus another one is which one? It is centchroman. Okay, that is Chaya, marketed by the name Chaya. So that's the 7th contraceptive one in the MEC wheel by the government of India, which is not blue, it is green in color. Okay, so that's another important update. So this is how the MEC, the different contraceptives in the MEC WHO wheel. In the government of India, you have one more, that is centchroman. Okay. Now coming to, so we know contraceptive methods are divided as temporary, permanent and emergency. In temporary, you have natural methods, barrier methods, intrauterine devices and hormonal contraception. We won't go into too much detail. I'm repeatedly saying this because it's a common topic, but let's discuss at least the questions which have come in the past and the ones that can potentially come. So in the natural methods, you have the calendar method, that is the rhythm method, the BBT method, that is basal body temperature method, symptothermal method. Okay, so symptothermal method is a combination of the calendar plus the basal body temperature plus the cervical mucus method. So that is the thickening of the cervical mucus at ovulation. If you combine all 3 methods, it becomes the symptothermal method. Then the WHO also uses a cycle beads method, which is used for the rural areas. Then, of course, coitus interruptus, lactational amenorrhea, and abstinence. Okay, so in these, all of these, I'm not going to discuss them. much, but what is important in these is the lactational amenorrhea method. Questions come on this. The primary question is that what is this method and why is it effective? So a woman who is lactating has high levels of prolactin, and prolactin is known to cause inhibition of ovulation. So that's the mechanism of action. That's how we know it will work. Okay, but to recommend this method to a woman who is lactating, she should fulfill the 3 Bellagio criteria. The first criteria means her infant should be less than 6 months old. The second is that she should be exclusively or almost exclusively breastfeeding. And the third, she must be amenorrheic. That means she should not have got her period. If all 3 are fulfilled, then only you can tell her that yes, LAM can be used as an effective natural contraceptive method. Now, in barrier methods, you have 2 types. One is there's an actual physical obstruction from the sperm reaching the ova, and the second is spermicidal methods. They also come under barrier. They immobilize the sperm. Okay. Now, in barrier, we have the male condom, we have the female condom. Remember, both are single-use disposable, although there is a slight controversy on the female condom where they can use it for 1 or more times. Okay. There are different guidelines recommending different things, but for all practical purposes, they are single-use disposable condoms. The female also has an option of using this. This is a cervical diaphragm or a cervical cap. In both, the mechanism of action is similar. Both have to be inserted before the act and can be removed a few hours after the act. Also remember that they do protect against STDs to a good extent, and the only disadvantage is that it needs to be learned how to fit in. Okay, it also is important. It cannot be used when the uterus is in a different position. For example, if there's a prolapse or there's a retroverted uterus, then it becomes difficult to fit in. Okay, so the cervical diaphragm and the cervical cap. Now, spermicide, this comes very commonly as an image-based question. Today, this is the brand name. It contains nonoxynol 9 is a very commonly used spermicide, but it's never used alone. It's used in adjunct with another contraceptive method, preferably. And this is something which is new. It's not yet available in the Indian market. This is called as Phexi. And the components of Phexi, what they do is they reduce the vaginal pH. They make it very, very acidic. Okay, and inhospitable for the sperm to survive. So it's like a spermicide. It's a foam. So this is the inserter. It is when it is inserted inside the vagina before the act of coitus, it leads to change in the vaginal pH, making it into a very acidic environment. Now, intrauterine devices are very important. Questions come on all 3. The first is the first generation one, okay, which is an unmedicated device, and this is a Lippes loop. The second one is a copper-containing intrauterine device. This is a second generation one. And the third one is the progesterone-containing or the third generation intrauterine device, commonly called as, the commonest brand name available is the Mirena. So these are the 3 types of intrauterine devices. Primarily, how do they act? The Lippes loop and the copper T, they cause, especially the copper T, they cause chemical and cellular changes in the endometrium, making the endometrium unfavorable for implantation of the embryo. Okay, so unfavorable implantation is one of the primary mechanisms of action. Also remember, it acts also by increased tubal motility, impaired sperm ascent, and LNG-IUD, the third generation, also causes endometrial atrophy. Remember, any progesterone-containing contraception, whether it is the implant, the Mirena, the injectable, it's going to act by causing these 2 mechanisms, endometrial atrophy and cervical mucus thickening. So Mirena is going to act by this in addition. Now, when all can you insert a copper T? Very importantly asked questions. You can insert a copper T in the postpartum period. Now, in the postpartum period, there are several times you can insert. One is PPIUCD, that is post-placental intrauterine copper device insertion, which is given a big a promotion by the government of India to motivate women at the time of birth, and this should be inserted within 10 minutes of placental delivery. There's a special forceps called the Kelly's forceps, which is used to put in the intrauterine device. It can also be put in at the time of a cesarean section. So it's not only for following a vaginal delivery, even at the time of cesarean, you can fit in a copper T. Also remember, and this is recommended for the PPIUCD and the intracesarean and the early postpartum. Early postpartum means you're inserting it after 10 minutes to 48 hours following delivery. It's called an early postpartum insertion. This is for the copper T. The government of India is pushing the use of the copper T for these 3 times. And if the patient is not willing right now, she says, I'll think about it and come later, you can do a late postpartum insertion, which is after 6 weeks of delivery. So between 48 hours and 6 weeks, you are not putting in an intrauterine device. Only after 6 weeks can you put in an intrauterine device. This is the government of India. The WHO says after 4 weeks of delivery, you can put in an intrauterine device. So this is postpartum. The second time you can put in an intrauterine device is in the post-abortal period. Following a first or a second trimester abortion, you can put in an intrauterine device. The third time is interval. Interval means what? Whenever a woman, she can walk into your OPD, irrespective of pregnancy or abortion, she comes on a regular day and says, I want a copper T to be inserted. You can put in a copper T on any day of the cycle as long as you're reasonably certain she is not pregnant. And that's why the best time is actually in the proliferative phase. That means in the early part of the cycle before ovulation, because then you're sure that she is not pregnant, but it can be put anytime. Even if she's menstruating, you can put in a copper T. You just should be reasonably certain she is not pregnant, but the best time, of course, is the proliferative phase. And of course, you can put in an emergency contraceptive. You can use the copper T as an emergency contraception, okay? And that is within 5 days of unprotected intercourse, you can put in a copper T. Now, this is the copper T 380A. It's called 380 because that's the surface area of copper. It's called A because you have copper on the arms also. It's a T-shaped copper T. Its lifespan is 10 years and it's freely available by the government of India. Okay, the government of India also has the copper T 375, which is 5 years. That's how you remember it. 380A is 10 years. 375 or multi-load is 5 years. It doesn't have copper in the arms. It looks like this spear sort of structure with serrations on the arms, and this is so that it gets fixed into the endometrium and doesn't get expelled easily. Okay, both of them, both the copper T 380A and 375 are freely available by the government of India. They come with a barium sulfate stem so that it's visible on an X-ray. Okay, and they have a thread at the end which is used to identify that the copper T is there by the woman, and it's also easily used for removal. This is the LNG IUS. Most common one available is Mirena. This is how it looks like. It contains levonorgestrel. It contains 52 milligram of levonorgestrel and releases 20 microgram per day. Now, important about the Mirena is that it is acting by endometrial atrophy and cervical mucus thickening. It used to be available for use for 5 years, but now this has increased to 8 years. Okay, so we can use it an upper limit of 8 years now for contraception. And apart from that, there are many non-contraceptive benefits of the Mirena, and these include if the woman has heavy menstrual bleeding, if the woman has fibroids not distorting the uterine cavity, if she has endometriosis, if she has endometrial hyperplasia without atypia, if she has adenomyosis. So whenever you have a woman with heavy menstrual bleeding because of these reasons or just simply no other reason, you can put in a Mirena. It will act both as a contraceptive and as an effective method to reduce the bleeding. So these are the other uses. Menorrhagia, dysmenorrhea, you can also use it, but sometimes the dysmenorrhea may worsen with the intrauterine device. But endometriosis, symptomatic fibroids, endometrial hyperplasia, and adenomyosis are definitely non-contraceptive benefits of an intrauterine device. What are the absolute contraindications? That means the MEC4 of an intrauterine device. How do you remember this? You remember this. You can't get pregnant if you have an IUCD. So suspected pregnancy is a contraindication to an intrauterine device, whether it's copper T or Mirena. pregnancy suspected, don't put in a copper T. If there's an infection in the vagina or the cervix or the uterus, that means she's had post-abortal sepsis, puerperal sepsis, she has active vaginitis, she has acute PID, you will not put in the presence of ongoing infection. U is undiagnosed genital bleeding. She comes for a copper T insertion, but she says she's been having some intermenstrual bleeding. So until you know what the cause is, till you found out what the cause is, do not put in an intrauterine device for undiagnosed genital bleeding. C is cancer or malignancy, and which cancers will you not put in a copper T? For cervical, for endometrial, and for gestational trophoblastic neoplasia. You are not going to put in an intrauterine device. And D is distorted cavity. That means the endometrium is distorted, like a large fibroid or a submucosal fibroid or a Mullerian anomaly, a septate uterus. You're not going to put in an intrauterine device. So this is just the two common ones which I've told you, the copper T 380 and the multi-load. So copper T 380 is T-shaped frame. It has 380 millimeter square of copper. It is inserted using the no-touch withdrawal technique, supplied free of cost by Government of India, and 10 years. Multi-load, it is copper T on the copper on the vertical shaft only. Okay, it has serrated arms. It doesn't have a plunger, so you just have to insert it. There is no withdrawal technique or anything like that, and is 5 years. Now the copper T 200, this used to be available by the Government of India. It's no longer now supplied by the Government of India. It had 200 millimeter square of copper, and the lifespan was 3 years. And the 7-shaped copper T is not available in our country yet. It's called the GraviGuard in the shape of the number 7. This is for use for 3 years. Now coming to hormonal contraceptives, which are the important things that you should know. Again, it's a very long topic, but we're here for a quick revision. So let's discuss the important high yield topics. So you have combined contraceptive options, okay, where the pills are the most important, and then we will discuss the patch and the ring. And then you have the progesterone only, where you have pills, injectables, implants, and we've already discussed the Mirena. Now, in combined, remember you have estrogen plus progesterone. The estrogen component is relatively the same. It's ethinyl estradiol, and the progesterone component varies. If used correctly, they are very, very effective. The primary mechanism of action is inhibition of ovulation. So, if you are asked amongst all these 4 options, the main mechanism of action is inhibition of ovulation. Because it has progesterone, it also acts by endometrial atrophy, cervical mucus changes, and also the fallopian tube motility is affected. Now, again, MEC4. Remember, MEC4, absolute contraindications are the ones that you should know for all the contraceptives. What are the MEC4 for? Combined contraceptive pills. Now, remember, estrogen is bad for what all? This way you will remember better. Estrogen is bad. Estrogen is bad for any woman who's at risk of thromboembolism, any woman who is having a liver problem, any woman who's having a migraine problem, and any woman who is in the immediate puerperium, okay, because that is again a hypercoagulable state, and it's also bad for breastfeeding, but then it becomes MEC3, not MEC4. So these are the primary things we are not going to give the woman combined contraceptive pills. So look at the first one. If she is more than 35, taking more than 15 cigarettes per day, she is at risk of DVT. Similarly, postpartum breastfeeding less than 6 weeks. Again, postpartum non-breastfeeding also less than 6 weeks, you will not give because of the higher risk of DVT. So, breastfeeding plus minus less than 6 weeks, you're not going to give. Whether she has DVT, pulmonary embolism, ischemic heart disease, high blood pressure, SLE, all these increase the risk of her having a thromboembolism, so you're not going to give. Migraine, you're not going to give. Also, very important, I forgot to mention here, estrogen is bad for the breast. So, current breast cancer, endometrial cancer, okay, or hepatocellular cancer, you are not going to give. 3 cancers we are not going to give: breast, hepatocellular cancer, and endometrial cancer. If she's currently having estrogen containing contraceptives, are a big no-no. The liver, if it's bad, you're not giving. Major surgery again increases the risk of DVT. So you're not giving. So even if you don't remember these by word, what is important to understand is anyone at risk of DVT, okay, cancers, breast, endometrial, liver, okay, liver again is bad, so cirrhosis is bad, migraines, and if she's in the immediate puerperium within 6 weeks, you're not going to give the combined oral contraceptive pill. Now, again, very important question comes in: breastfeeding woman, can we give contraceptive pills? If she's less than 6 weeks, absolutely no. So, MEC4 if she's less than 6 weeks postpartum. If she's between 6 weeks and 6 months and she's breastfeeding, still do not give. It is MEC3. That means relatively contraindicated because estrogen reduces the quality and quantity of breast milk. So till 6 months, it's MEC3. And after 6 months, you can safely give the contraceptive pill. In fact, it's better. The benefits outweigh the risks. So please give the contraceptive pill even if she is breastfeeding after 6 months of post-delivery. Now, the advantages of combined pills are they are effective, there's easy return to fertility, there's no effect on future fertility, effective at all ages, independent of coitus, simple method to use, and has plenty of non-contraceptive benefits. What are these non-contraceptive benefits? In this, what you should remember, questions that have come: it reduces the incidence of PID, there's a reduced incidence of ectopic pregnancy also. It can be used in endometriosis, fibroids, we've already discussed this. Okay, it reduces the blood flow and the pain. So painful periods, heavy menstrual bleeding, it will reduce it. It prevents osteoporosis. Remember, estrogen is good for the bones. It reduces benign breast diseases. And very, very important, which question comes is, what cancers are reduced by the combined oral contraceptive pill? It will reduce colorectal, endometrial, and ovarian. So CEO, remember, colorectal, endometrial, ovarian is going to be reduced, and increases the risk of breast cancer, and in some studies also cervical cancer is also increased. So this is what you should remember about the combined contraceptive pill. Side effects are plenty. There are GI, headache, migraine, weight gain. Although the newer 4th generation progesterone containing contraceptives are known to lessen the weight and known not to cause acne. So it depends on the progesterone you are using. Okay. Otherwise, these are the side effects. Important in this is this one, the last one: breast cancer, cervical cancer, and liver adenomas. The risk is increased. Now, this is the most important thing nowadays, which usually every paper now a question is coming. And this I have taken from the Government of India document, Ministry of Health and Family Welfare, on how to manage a missing a pill. Now, if the woman has missed 1 or 2 pills, so whenever we're giving the pill, how are we giving? And we're talking about the Mala N. Mala N is the government supply one. So I'll just draw how the packet looks like so you understand better. So you have 21 hormonal tablets, and then you have 7 black colored iron tablets in the packet. This is how the packet looks like. I'll draw it as black only. Okay, now the woman is supposed to start taking the pill. Usually we tell them anywhere between the first and fifth day of the menstrual cycle, she starts taking a pill. She takes 1 pill every day, 21 days ke hormonal pills, and then 7 days of iron tablets, and then she starts a new packet on the 29th day. Usually when she's going to take the iron tablet, she's going to get her period, because that is when the withdrawal bleeding will happen. So this is how and then she takes it continuously, no break in between, because the 7 tablets are the iron tablets. So there is no break. The iron tablets prevent anemia, and they also maintain continuity of the packet. Now, if the woman has missed 1 or 2 pills, that means she's missed, suppose she comes to the question comes, she's missed taking the pill on day 14 and 15, what do you do? Or she started the new packet 1 or 2 days late, what do you do? So in such a situation, just tell her that the risk of pregnancy is very less. If efficacy would not have been compromised by missing 1 or 2 pills, just tell her, just take yesterday's pill now, take the last missed pill now, or take 2 pills together today. That means today's pill and yesterday's pill, take it together. That's all you need to tell her. So 1 or 2 pills, this is, I'm talking about the hormonal pills. If she's missed an iron tablet, it doesn't matter, leave it, let it go, continue the packet. Okay. But take 1 hormonal pill as soon as possible, or 2 pills at the scheduled time is what is to be done. Now, problem comes if she's missed 3 or more pills. If she's missed 3 or more pills, now definitely contraceptive efficacy is compromised. But you tell her we can lessen the effect. Let's see, maybe we can help you. What can we do? So ask her when she has missed the 3 pills. If she's missed it in the first 2 weeks, so day 1 to day 14 ke beech mein, if she has missed the tablet, then what do? Then you tell her take one hormonal pill as soon as possible. That means take the last pill as soon as possible and continue the scheduled pills. Continue the packet. Take the last pill as soon as possible. Continue the packet. But in addition, give her a condom for 7 days and ask her if she's had intercourse in the last 72 hours. Give her the emergency pill, which is the LNG 1.5 milligram pill is what the government of India recommends. So this is what is done if 3 or more pills are missed in the first 2 weeks. If 3 or more pills are missed in the 3rd week, okay, what should she do? It's the same thing, okay. So take one hormonal pill as soon as she remembers, okay. So if she's missed 3 pills in the 3rd week, that means in this week, 1, 2, 3, 4, 5, 6, 7. Yahan pe she has missed 3 or more pills. What should she do? Take the last missed pill as soon as she remembers, okay. Then what should she do? She should start use a backup method for 7 days. Give her the LNG IOD, and very, very importantly, what does this mean? This means that she should take the last missed pill, continue the packet and finish the hormonal pills. Do not take the iron pills. Instead of taking the iron pills, start a new packet immediately from day 22. That means the 7 iron tablets which we give when she's going to have withdrawal bleeding, nahi dena, it's not to be given. Tell her to start a new packet from here itself. From this point, day 22 onwards, a new packet is to be started. She's not taking the iron pills. She just takes the, suppose she missed the pill on, say, day 15, 16, 17 and she's come to you on day 18. What do? Tell her, take day 17 wala pill, take it now. Continue the remaining hormonal pills. Don't take the iron pills. Start a new packet on day 22. Use a condom for 7 days and give her the emergency pill. So that's what has to be done. But this is very important to understand. Take some time out. Sit and study with this. Understand this. Repeat it or discuss it with somebody else. Make up scenarios in your mind. Do questions on this and then move forward. It's very volatile. You tend to forget this, but it's a very important topic. What about the vaginal ring? This is also an estrogen plus progesterone containing contraceptive. It contains ethinyl estradiol plus the progesterone component is something called as etonorgestrel. Now with the ring, remember it is to be worn for 3 weeks and then 1 week gap. In that 1 week gap, she's going to get her period. Then again, she starts wearing a new ring. So every cycle, she has to wear a new ring. 3 weeks on, 1 week off. 3 weeks on, 1 week off. Mechanism of action is same as the combined pill. Similarly, patch. Patch contains ethinyl estradiol plus the progesterone component is norelgestromin. Now again, how does she wear this? This is a transdermal patch. Stick it on the skin. Usually we advise on the arm. It can be applied anywhere on the body except the breast. Do not apply on the breast because of the higher incidence of theoretical risk of breast cancer. Okay, now how is this used? So every week a new patch. So 1 week plus 1 week plus 1 week. So new patch every week and then 1 week patch free. This is the time she's going to get her withdrawal bleeding or her period. And then start a new patch after that 1 week patch free interval is gone. So every week a new patch is used. Now coming to the progesterone only contraceptive. So we have progesterone only pills, then injectables, then implants, and then the Mirena. Progesterone only pills contain only progesterone. They are also called as mini pill. They are effective, okay, but with typical use, they are not very effective. Why? Because they need to be taken at the same time every day. Even a gap of 3 or more hours can compromise the efficacy. So she has to fix a time. That's very important to stress that she has to fix a time and take it the same time every day. They are taken continuously. There is no gap with the progesterone pill. There is no pill-free interval. Okay, the only absolute contraindication is breast cancer. The mechanism of action for all progesterone contraceptives are endometrial atrophy and cervical mucus thickening. So important to remember here, same time every day. What is this? This is Antara. It is an injectable progesterone containing depomedroxyprogesterone acetate. It is given as a deep intramuscular injection every 3 months, okay, and it contains 150 milligram of DMPA. Now, with progesterone only contraceptives, remember the few side effects. They cause a lot of irregular spotting and bleeding in between, okay, and they can even cause long periods of amenorrhea. So these are the two side effects of even the PO pill, the injectable, the implant, and even the Mirena. It will cause irregular bleeding and a lot of periods of amenorrhea. Now, in Antara, what you should remember, apart from these two, there is also a delayed return to fertility. That means once she stops the Antara, she may not get pregnant for 6 to 12 months. It may take 6 to 12 months for her to get back her fertility. It's very strong. Okay, so and it's very effective also. So DMP, what should you remember? Intramuscular 3 months, 150 milligram injection every 3 months is given. Okay. Now with Antara, remember there is a new formulation. I'll just come back. There's a new formulation called subcutaneous DMPA. And this contains 104 milligram of DMPA. Otherwise, everything else is the same. The only thing is the route is different. The dose is different. The best thing about this, it's in a very easy to inject packing. So the woman can inject it herself. Many times they miss the time they have to go to get the 3 monthly injection. They can't go to the PHC for whatever personal issues. So this is self-injectable. She can inject it herself every 3 months. That's the biggest advantage newly introduced in our country. Now, this again is a very commonly was asked very recently, what to do if she comes late for the injection or if she comes early. So she had to get the injection at 3 months, but she has come at 2.5 months. Should you tell her, no, come after 15 days? You never know, she may not come again. So give it to her. So if she comes up to 2 weeks early or up to 4 weeks late, that means anywhere between 2.5 to 4 months, she comes. She's supposed to come at 3 months, but she's come between 2.5 to 4 months. It doesn't matter. It's safe. Give her the injection. No backup required because I told you DMPA has a delayed return to fertility. But if she comes after 4 months, she had to come every 3 months, but she comes after 4 months. Then what do? Then you have to do a UPT, rule out pregnancy. If not pregnant, give her the injection. Tell her to come on time the next time and give her a condom for 7 days. Use a backup method for the next 7 days. So this is what to do if she comes late for the DMPA injection. This question was recently asked in the INI-CET. Now, implants were not very commonly asked in the exam, but now they may be because they are again been recently introduced in our country. Progesterone implants, again, they act because of progesterone, endometrial atrophy, cervical mucus thickening, breakthrough bleeding, amenorrhea, all that is there. But they have a quick return to fertility. So the day you remove it, they are immediately fertile. So that's an advantage. Okay, another thing is they are the most effective temporary method of contraception. They have the best efficacy. If the question comes best efficacy, answer is a progesterone implant. Which one of these has been recently introduced in India? Is the Implanon Next. Okay, so the Implanon Next, which contains what? It contains etonorgestrel. How much? 68 milligram in a single rod. Okay, is the implant. So a single rod subdermal implant containing etonorgestrel, and it is effective up to 3 years. This is important to remember. What else should you know? You should know it is 4 centimeters. It's a 4 centimeter rod. It is again radio opaque because it has barium sulfate. Okay, and where is it inserted? It is inserted in the non-dominant hand. That means if she's right-handed, put it in the left hand. So non-dominant hand. Okay, and what you do is you feel for the medial epicondyle, 8 centimeters upwards of the medial epicondyle. Okay, so 8 centimeter upwards. And then you ask her to tighten her muscles. So the groove between the biceps and the triceps, 3 to 5 centimeters below that, and 8 centimeters upwards of the medial condyle. At this point is where you put the applicator and you insert it after injecting local anesthesia. So in the non-dominant hand, under local anesthesia, 8 centimeter upward from the medial epicondyle, 3 to 5 centimeters below the groove between the biceps and the triceps is where this rod is inserted. For removal, you give a small incision under local anesthesia and you pull out the rod. 3 years is the duration. Okay, and immediate, it is effective as soon as within 24 hours of application of the implant, it is effective, and it is has immediate return to fertility on removal. Okay. Now, the Mirena we have discussed in detail, so already been discussed, so I'm not discussing it here. Now, an Indian made contraceptive, and because it's Indian made, it's very likely to be asked in the exam, is Centroman. Centroman is it's basically a selective estrogen receptor modulator. And important to know is that it is marketed in India by the name of Chaya, earlier Saheli, now as Chaya. How is it given? It's given twice a week for 3 months. Okay, and then you give it once a week for whenever she wants to continue the packet. Okay, so this is what is about Centroman. What are the MEC4 for Centroman? This is again from the Government of India document. It is contraindicated in polycystic ovarian disease, in cervical hyperplasia. By cervical hyperplasia, I think they mean cervical intraepithelial neoplasia, that is CIN or cervical cancer. Okay, then liver disease, it is contraindicated. Any allergy, it is contraindicated. And chronic illnesses like renal disease or tuberculosis, it is contraindicated. But remember PCOS. PCOS, it is contraindicated. That's a very important contraindication you should remember for Centroman. Question comes on LARC, long-acting reversible contraceptions. Remember the 3 I's. You have injectable, you have intrauterine devices, and you have the implant. Okay. And very commonly asked is the emergency contraception. So what are the emergency contraceptive methods that we have available? We have the use-based regime, no longer used now, used maybe 15-20 years back. When I was a postgraduate, we used to give this. So what do? You give a high dose of a estrogen containing contraceptive pill. So that would be around 100 micrograms of ethinyl estradiol plus 0.5 milligram of levonorgestrel. So 2 tablets of a high dose containing combined contraceptive pill, and repeat the dose 12 hours apart. It can be given up to 72 hours of unprotected coitus. What is available in our country now by the Government of India, however, is LNG. That is the easy pill. It's called available by the name easy pill. One single tablet containing 1.5 milligram of LNG up to 72 hours of unprotected coitus is what is the preferred regime in India. However, if you ask, the best one, not in India overall, is ulipristal acetate, because this is more effective than LNG, and it can be used up till 5 days. So, single 30 milligram tablet of ulipristal acetate can be given within 5 days of unprotected intercourse. And also intrauterine copper devices. A single IUCD can be inserted up to 5 days of unprotected coitus. This is preferred in those women who are also looking for a LARC, long-acting reversible contraception. Then it's best to put in a intrauterine device. So now we move on to gynae oncology, and in part 1 we'll be discussing cervical and endometrial cancer. In part 2 we'll be discussing ovarian cancer. Starting with pre-invasive cervical lesions. So before cervical cancer, we discuss pre-invasive cervical lesions. That means the pre-malignant conditions for cervical cancer. And for that, it's important to understand that when we talk about cervical cancer, we need to understand that the primary area of the cervix where cancer can happen is something called the transformation zone, which is what you see here. This area between the purple line and the yellow line, between these two, all this area here is the transformation zone. It is nothing. So the area between the original squamocolumnar junction and the new squamocolumnar junction, the outer one is the original junction and the inner one is the new junction. So the area between the original and the new squamocolumnar junction is the transformation zone, which is most prone for malignant change. Now, when we talk about cancer screening, remember that guidelines have now changed. So the preferred modality of screening by most guidelines now is an HPV DNA test. So a cervical smear is taken and sent for HPV DNA testing. This is the preferred modality, and this should be done once every 5 years. However, many places are still doing a pap smear. If you're doing a pap smear, it should be done every 3 years. Okay. Testing is usually recommended between the ages of 25 to 65 years. There's something called a co-test. A co-test is if you're doing both together. An HPV plus a pap smear is called a co-test. If you're doing a co-test, this is also done once every 5 years. Okay. Now, how do you take a pap smear? Can you see these instruments here? These instruments are used to take a pap smear. You have a Cusco speculum. Okay, and when you put the Cuscos, you visualize the cervix and you use the air spatula to take a sample from the ectocervix. You use this cyto brush to take a sample from the endocervix. You make one slide of the ecto, one of the endocervix, and you put it in the jar containing the fixative, or you spray the fixative on the slide, and the fixative contains 95% ethanol. Okay, so all of this is important. Everything has come as a question. So this is important to know. Now, how do you test for HPV? HPV is similarly, you take a smear from the cervix, you put in a Cusco speculum, and you use a cytobroom. This instrument you're seeing is a cytobroom, which is used to take a smear, and this is sent for HPV testing. What are the other methods of cervical cancer screening, which you should know? The one you're seeing here is visual inspection under acetic acid, where acetic acid is put on the cervix, and if there's any pre-malignant or malignant area, it becomes aceto white in color. That means white in color, like this area here. So you know this is an abnormal area, and you know you should take a biopsy from this area. Similarly, there's something called as VILI. VILI is visual inspection under Lugol's iodine. Remember, when you apply Lugol's iodine to normal tissue is going to get stained by the iodine, whereas a pre-malignant area is not going to get stained. It is iodine deficient. So again, you know where you're going to take the biopsy from. Now, I told you have a co-test, which is taking both a HPV plus a pap smear. A reflex testing is also taking both an HPV plus a pap smear. But in a reflex testing, the lab is first going to check the HPV status. Only in those women whose HPV is positive are they going to further process and look at the pap smear. If it's HPV negative, they won't bother looking at the pap smear. Now, when a pap smear is taken, okay, so when a pap smear is taken, what are the possible lesions that can come? This is a normal thing. If it comes as negative or NIELM, NIELM is negative for intraepithelial lesion or malignancy. This means it's normal, nothing to worry. These are all abnormal findings, starting from ASCUS, ASC-H, LCIL, HCIL, or frank squamous cell carcinoma. You can even have glandular cell abnormalities. These are endocervical abnormalities, but these are not important. What you should know are the epithelial cell abnormalities. Now, what to do, or how will the question come? The question will come that a patient came for routine HPV screening, HPV was taken, HPV came positive, what should you do? So, if HPV is negative, you are not worried. You just return her to call her back after 5 years. But if HPV is positive, then ideally you should do what? Ideally, you should call her for a pap smear. And then depending on the report, anything which is more than ASCUS, that means anything which is not normal, you should do a colposcopy and biopsy. What is colposcopy? It is looking at the cervix under magnification so that abnormal areas are well visualized and you can take a biopsy from an abnormal looking area. This is what you should ideally do. But many patients will not come back for a pap smear. They will say, you're wasting my time. What should I do? If so, you can directly also, if HPV is positive, say, not taking any risk, let's do a colposcopy and a biopsy. The other way the question can come, because many places we're still doing a simple pap smear. So what do you do in case of an abnormal pap smear? Cytology means an abnormal pap smear. Pap smear is looking at abnormal cells. So it's an abnormal cytology. So if it is NIELM, the first one, the normal one, what will you do? You will call her back after 3 years because it's normal. But if it is anything above ASCUS, then you need to be more vigilant. So if suppose it comes as ASCUS, atypical squamous cells of undetermined significance, then you take an HPV. If the HPV is positive, you have to send her for a colposcopy because two things are there. Now, ascus bhi hai, HPV is also there. But if HPV is negative, then call her back now after 5 years because you've done a co-testing, you've taken an HPV, you've taken a pap smear, it's normal. HPV is negative, no need to worry, call her back after 5 years. If it comes as L-cell is low-grade squamous intraepithelial lesion. Again, if HPV is positive, then directly do a colpo and biopsy. If HPV is negative, then you can call her back, not after 5 years though, call her back at 1 year. But if it is HSIL or ASC-H, high-grade squamous intraepithelial lesion or atypical squamous cells of high grade, then you don't even need to do an HPV because it's come as high grade on the pap smear. Directly send her for a colposcopy and biopsy. So if it's HPV positive, you're doing a colposcopy biopsy. If it's an abnormal cytology, you're doing an HPV in low-grade lesions. If it is positive, sending for colpo biopsy. But any high-grade cytology, you're directly doing a colpo biopsy. What is this? This is how a colposcope looks like. So you're visualizing and the image is transmitted on a screen. So you see the cervix on a screen. You see any abnormalities on the cervix and you can take biopsies from abnormal lesions. Now you've taken a biopsy from an abnormal lesion. You've done a colposcopy, you've done a biopsy. What are the possible things? It could come normal. It could come as CIN, cervical intraepithelial neoplasia 1, CIN2 or CIN3. CIN1 is usually a low-grade lesion. So if you have L-cell or ASCUS, you usually expect CIN1 aega biopsy mein. If it's a H-cell or ASC-H, you usually expect CIN2 or 3 to come. So if it is a CIN1, remember CIN1 is a low-grade lesion. So what can you do? You can choose to just keep her on, if she's willing to follow up, call her after 1 year. But some of these patients are very apprehensive or you're not sure if she'll come back. You can also do a cervical ablation. So CIN1, what do? You used to do an ablative procedure. Ablation means you are burning or freezing the cervix, the transformation zone. Okay. And if it's CIN2 or 3, now here you're more worried, it is a high-grade lesion. So here you would prefer an excisional procedure. That means you're going to excise the transformation zone. So this is an ablative procedure. This is a procedure showing a cryotherapy. So you can either freeze the cervix using nitrous oxide or carbon dioxide. Nitrous at minus 89 degrees Celsius is usually what is used. Or you can burn it. That is thermal or laser ablation. So burn it with electrical energy or laser energy, burn the cervix, and this will destroy up to a depth of 5 millimeters of the surface of the cervix. But if it is CIN2 or 3, it is better to do an excisional procedure. What is this image showing? This is showing a large loop excision of the transformation zone, what is called as LLETZ. Or you can do a LEEP. What is LEEP? LEEP is loop electro excisional procedure. It's the same thing. It's just got two different names for it. It's the same thing. LLETZ is also called as a LEEP. What is this picture showing? If you want more tissue, you're doing an excisional procedure, but you want more tissue because you're suspecting that maybe there is a malignancy or a underlying pre-malignant high-grade lesion in the endocervix. So you want more, you want to go deeper. You can do a cone biopsy. This is a cone biopsy. Here we're taking out a cone-shaped structure from the cervix, including the transformation zone here, and going inside the endocervix. This is when you're suspecting endocervical involvement, or when you've done a colpo biopsy, but the margins of the biopsy are positive. So positive margins, you know you have to take out more tissue now. Or if you have a discrepancy between the pap smear and the colpo, that means suppose your pap smear comes as HSIL, a high-grade lesion, but your colpo shows CIN1. It is not going together. That means maybe you are missing some lesion, so you want to take a deeper biopsy. Okay, and the fourth one is if you're very strongly suspecting a carcinoma, then it is better to do a cone biopsy because whatever you're going to take out from LEEP or from cone, you are anyway going to send this for a biopsy again. Okay. Now coming to the HPV vaccine. HPV vaccine is very important these days. It's going to come as a question. 100% sure it's going to come as a question. It primarily prevents against CIN1 and CA cervix, but also against CA vulva, vagina, anal canal, penile, oropharyngeal, and also genital warts. This comes as a question several times. It contains the L1 synthetic capsid protein. What are the types of vaccines? We used to have the bivalent, but now we have two types of quadrivalent vaccines, out of which Servavac is the newest kid on the block. This is the Made in India vaccine, which is a quadrivalent against 6, 11, 16, 18. Remember, 16, 18 are the high risk types, 6, 11 are the low risk types. 6, 11 cause genital warts, 16, 18 cause cervical cancer. And the recent most one is, not the recent most one, it's been many years now, this Gardasil 9, recently introduced in India, is both Servavac and Gardasil 9. Gardasil 9 is nonavalent, 9 genotypes against it is effective. Okay, if you can remember the 9 genotypes. What does the Indian Academy of Pediatrics says? What is the dosing schedule? If she's between 9 to 14 years, then 2 doses are required. But if she's 15 or more, then complete 3 doses are required. The age group of vaccination is 9 to 26, ideal age. Okay, but the Gardasil people say you can even vaccinate till the age of 45 years. This is for Gardasil, not for Servavac. Okay. Now, the WHO in 2022 came out with something called the Strategic Advisory Group of Expert Committee, said that if the girl is less than 20 years old, so 9 to 14 or 15 to 20. So if she's less than 20, even 1 or 2 doses is enough. You don't have to give 3 doses. You don't even have to give 2 doses. 1 or 2 is enough. And if she's more than 20, then 2 doses is enough. You don't have to give the 3 doses also. But if she's immunocompromised, like HIV positive, then you should give all the proper 3-dose schedule. Now coming to cervical cancer. And in cervical cancer, remember that we know the primary risk factor is HPV. So that's what you need to remember. Apart from this, the risk factors for HPV could be early age at intercourse, multiple sexual partners, PID. All that will increase the risk of cervical cancer because that is increasing the risk of HPV infection. Okay, so we know human papilloma virus is what causes it. And we know that the main 2 types, the most common type, however, is squamous cell carcinoma. If it is an endocervical cancer, then adenocarcinoma can be seen. How will this patient present with CA cervix? She will present with the classical symptoms. What are the classical symptoms? They could be intermenstrual bleeding. They could be post-coital bleeding. If she's post-menopausal, then post-menopausal bleeding. And there could even be a history of foul smelling, vaginal discharge, along with loss of weight and appetite, so cachexia. When you examine her, what are you going to see? You're going to see a fungating or an ulcerative growth on the cervix, which is friable. That means it melts in your hand if you touch it. Okay, and it bleeds on touch. This is how it appears. And if you see something like this, a growth on the cervix, what should you do? You should take a punch biopsy using this instrument, which is a punch biopsy forceps. You should take the biopsy from the periphery of the lesion as against the central part of the lesion. Now, staging of cervical cancer, remember, is a clinical staging with the help of investigations and examination of the patient. You're going to stage cervical cancer clinically. And this is one staging that you need to remember. What is stage 1? Stage 1 is cancer limited to the cervix. So, stage 1 is limited to the cervix. Okay, and you can divide this as stage 1A and 1B. 1A is microscopic invasion. It's not visible. And 1B is macroscopic, that means it's visible. So this you can further divide as 1A1 and 1A2. 1A1 is when the depth of invasion is less than 3 millimeter. A2 is when it is 3 to 5 millimeter. Okay, and once it's more than 5 millimeter, it becomes 1B. And this you can further divide as 1B1, 1B2, 1B3. 1B1 is 5 millimeter to 2 centimeter. B2 is 2 to 4 centimeter. And B3 is more than 4 centimeter. So this is stage 1 limited to the cervix. Stage 2 is what? Stage 2 is a lesion which has now gone beyond the cervix, and in stage 2A, it is gone till the upper part of the vagina. Again, you can have further divisions based on size 2A1, 2A2. So 2A1 is less than 2 centimeters, 2A2 is more than 2 centimeters, but it is in the upper part of the vagina. 2B kya hai? 2B is gone inside the parametrium, but not till the lateral pelvic wall. Now remember, here only I'll tell you, if it is less than 2A1, so till here is where surgery can be done. Anything more than 2A2, in fact, even a 1B3, because it's very big in size, should not be managed surgically. Here you would prefer radiotherapy, chemoradiation, if it is 2A2 and beyond. Okay. What is stage 3? Stage 3 is, now you can further divide this as 3A, which is when it's gone till the lower part of the vagina. 3B, when it's gone till the lateral pelvic wall, and here is where you sometimes see hydrouretronephrosis. And 3C is when it's gone till the pelvic or para-aortic lymph nodes. Primarily, it will go first to the pelvic lymph nodes. And stage 4 is local metastasis, stage 4A, or stage 4B is distant metastasis. So this is the staging. It's a very simple staging. It's a very important staging from the exam point of view. So for cervical cancer, we have two modalities of treatment. Till stage 2A1, you can do surgery. Okay, till 2A1. This is excluding large 1B tumors. 1B3 will usually not do surgery. And chemoradiation, remember this is chemoradiation, can be done in all stages, especially for later stages. By later stages, I mean anything more than 2A2, you will do chemoradiotherapy. But chemoradiation can be done for all stages. Now, just in a quick table, what is the surgery you do? Now, if it is 1A1, that means the depth of invasion is less than 3 millimeter, and there is on the biopsy, the pathologist says there is no lymphovascular space invasion. Remember, cervical cancer, the primary mode of spread is lymphatic spread. So, if the biopsy is telling you there is no invasion of the lymph space, then you can even just do a cone biopsy. If she's young, if she's older, you can do a simple hysterectomy, a type 1 hysterectomy. You're not doing any radical hysterectomy. If it is very small, micro-invasive, less than 3 millimeter with no lymphovascular space invasion. But the same thing, less than 3 millimeter, but it has entered the lymphovascular spaces. Here you will do a type 2 radical hysterectomy. Okay. And whenever you're doing a radical hysterectomy, you're always removing the pelvic lymph nodes also. Okay. Once it becomes 1A2, that means it is now 3 to 5 millimeters, still microscopic, but 3 to 5 millimeter. Here onwards, you will be doing type 3 radical hysterectomies. But if the woman is young, in these cases, type 1A1 or 1A2, you can even do a radical trachelectomy, that is, preserve the uterus, remove the cervix, okay, and the paracervical tissue. If she is 1B1, that is a small 1B tumor, a small visible tumor on the cervix, again a type 3 radical hysterectomy with pelvic lymphadenectomy. And usually, so 1B1, I will also write here 1B1, 1B2 and 2A1. For all these, you can still do a radical hysterectomy. So small 1B tumors and small 2A tumors, you can do a radical hysterectomy. But 1B3, 2A2 onwards, you will do chemoradiation. This is a specimen of a radical hysterectomy, okay, where you remove the uterus with a part of the vaginal cuff, with the tubes, the ovaries, the parametrial tissue, and the lymph nodes. Now, it's important to understand which lymph nodes are removed in a radical hysterectomy. You remove the common iliac group of lymph nodes, you remove the internal iliac, the external iliac, the obturator group of lymph nodes, and the sacral group of lymph nodes. So, common iliac, internal iliac, external iliac, obturator, and the sacral lymph nodes. Now coming to endometrial cancer. Now in endometrial cancer, remember that we have two types of it. We've already discussed endometrial hyperplasia earlier on along with AUB. That is the pre-invasive lesion for endometrial cancer. Here we'll concentrate on the actual cancer. So you have type 1, that is endometrioid, which is estrogen dependent. I was telling you, endometrial hyperplasia and cancer are estrogen dependent. Okay, whereas non-endo and non-estrogen or estrogen independent tumors are type 2 cancers. These are much rarer, they are higher grade, and they have poorer prognosis. Now, how will endometrial cancer present? So, usually before that, the risk factors. This is usually seen in the post-menopausal age group. Okay, and they present with post-menopausal bleeding. This is the common finding. And when you examine her, you'll usually find a normal sized uterus. Endometrial cancer will not increase the size of the uterus too much. Okay, but postmenopausal bleeding is the most important symptom. Now, what are the risk factors? The risk factors are women who have more exposure towards estrogen, like if they are nulliparous or they have an early menarche, late menopause. Okay, or women who have PCOS, women who are exposed to a drug called tamoxifen. Okay, these are women where the estrogen content is higher, women who have fibroids, women who have endometrial hyperplasia. These are all women at risk of endometrial cancer. Now, how will you diagnose this? So, when you have this woman who comes with postmenopausal bleeding and a normal size uterus on examination, when you do the scan, you find a thickened endometrium, like we discussed in endometrial hyperplasia, right? And if you find this thick endometrium, what will you do? You're going to advise her a endometrial biopsy, preferably a hysteroscopic guided endometrial biopsy. This is an image showing the endometrial sampler or the aspirator, which is an office procedure where you can simply do an office biopsy, which doesn't require cervical dilatation. Or you can do a dilatation and curettage. This is a procedure showing a dilatation and curettage where you're actually taking the sample from inside. So that's a sim speculum. Quickly revise the instruments here. Also sim speculum. Valsalum is holding this anterior lip of the cervix. Then what is being done? Then Hagar's, the sound is being done. The uterus is sounded to see the size and direction of the uterus. Then Hagar's dilators are being used to dilate the cervical, the internal os. Those are different Hagar's dilator. We dilate till we are able to introduce the curette. And when we're taking an endometrial biopsy, we use the sharp end of the uterine curette. So now we take the sharp end of the curette, okay, and we curette out all the endometrial tissue. So this is a dilatation and curettage. All the tissue you can see is coming on the gauze piece, and then this will be sent for sampling. But you can see it's a blind procedure. I don't know what's inside the uterus. I am just curetting out all the walls. I may miss some tissue. So that's the tissue being sent for the curettage, okay. Or you can actually do, and what should be done is this procedure. You're doing a hysteroscope. You're looking inside the uterus. You're looking at abnormal tissue and you're taking samples from that abnormal area. So you know which wall abnormal tissue is there, and you're not going to miss any significant area. So you're looking inside the uterus. So looking inside the uterus and taking biopsies from any abnormal areas. So that's inside the uterus. This is also a woman who had come with postmenopausal bleeding, and we're taking an endometrial biopsy for her. Okay. Now, staging of endometrial cancer is not very important. Okay, just remember the main ones. Stage 1 is tumor confined to the corpus uteri, that means the uterus. Stage 2 is tumor invading the cervical stroma but not extending beyond the cervix. Stage 3 is local and or regional spread, and this includes lymph nodal involvement. And stage 4 is bladder bowel mucosa or distant metastasis. Never been asked, not very important according to me. Okay, so you can skip the staging if you're too overwhelmed. Treatment is mainly surgical, that is, you're going to do a TAH plus a BSO. You're going to remove the uterus and the tubes and ovaries, and this patient is going to require post-op chemotherapy and radiotherapy. Remember, endometrial cancer is surgically staged. Okay, like ovarian cancer, it is a surgical staging, whereas cervical cancer, vulval cancers are clinically staged with the help of investigations. Endometrial ovarian, you're always going to do surgery because you have to surgically stage the disease. Okay, so now we move on to revision of ovarian cancers, which is again a very important and a little bit vast topic. Starting with benign ovarian cysts. Now, in benign ovarian cysts, we have functional ovarian cysts, we have benign neoplastic cysts, we have functional ovarian, and we have endometriotic cysts, and here we have others. Okay, like tube ovarian masses. So others comes in para-ovarian cysts. So we have functional, benign, endometriotic, and others. Now coming to functional cysts. Functional cyst means a cyst which is because of increased activity, and this could be a follicular cyst, which is nothing but an unruptured Graafian follicle, or it could be a luteal cyst, which is very commonly seen in pregnancy, like in twin pregnancy or in molar pregnancy. Because of rising HCG, the ovaries increase in size and form luteal cysts. This is how a follicular cyst will look like. This is the cyst contains a simple cyst. It just contains follicular fluid. That's why it is black in color. Anything black is fluid. So this is the cyst. Okay, and what should you do? And a luteal cyst is when it's either a corpus luteal cyst which has not ruptured, or it is a theca lutein cyst or a luteal cyst of pregnancy, which I just told you is very common in molar pregnancies and multiple pregnancies. Now, if it is a simple functional cyst like this, the scenario which will come will be a 25-year-old woman presents with vague abdominal pain. On an ultrasound of 5 centimeters, simple cyst is found. Her LMP was 2 weeks back. That means she's not pregnant. What do you do next? So, if it is less than 5 centimeters, and some books say less than 6 centimeters. Okay, so I'm going to write here less than 5 or less than 6 centimeters, because Novaks, one of the standard books, gives it as 6 centimeters. And it's a simple cyst. You don't have to do anything. By simple cyst, I mean a simple black looking anechoic cyst on the ultrasound with no worrisome features at all. Simply observe for 3 to 6 months, or another option is give her 3 cycles of oral contraceptive pills. This will cause dissolution of the cyst. Okay. But if it is between 6 to 8 or 5 to 8 centimeters, okay, what should you do? Then you need to observe this patient more carefully. Look for any worrying features on the ultrasound. Do a CA125 level. So if there are any raised CA125 levels, if there are any worrying features like solid areas, or it is multicystic, then surgery would be advisable. Okay, and what surgery? The surgery preferred is laparoscopic ovarian cystectomy, unless you're suspecting malignancy. Okay, but if it's more than 8 centimeters and it's a simple looking cyst, it is definitely surgery. Okay, you're not going to wait on an 8 centimeter cyst to disappear by itself. Now you're at risk of it rupturing or undergoing torsion or having hemorrhage inside it. So the patient can come with acute abdominal pain. So if it's a more than 8 centimeter cyst, do a laparoscopic ovarian cystectomy. Now, when it comes to benign masses, it could be a benign epithelial tumor like a serous cyst adenoma, a mucinous cyst adenoma, or it could be a benign germ cell tumor, the most common of which is a dermoid cyst, or it could be a benign sex cord stromal tumor, which could be fibroma, or a functional benign sex cord stromal tumor. So you can have non-functioning or functioning mesenchymal tumors which are benign. Now look at these pictures. What is this? This is showing a serous cyst adenoma. It looks like a anechoic simple cyst, and on histopathology, on gross and microscopy, you can see the psammoma bodies. This is a serous cyst adenoma. This is a mucinous cyst adenoma, which can become very large in size. They are more likely to be unilateral, but they are more likely to be multilocular, and they have mucinous material, which when they can spill can cause pseudomyxoma peritonei. Then there's something called Brenner tumor, which is a rare, mostly benign tumor. It has the typical coffee bean nucleus. Coffee bean nucleus is also seen in granulosa cell tumor. So it's seen in both granulosa cell tumor and in Brenner tumor. They will have, on microscopy, they'll have transitional epithelium, and they usually present in the menopausal age group. Dermoid is where questions are commonly asked. This is a typical image-based question, how it will appear. It has matter from all 3 germ cell layers. So you have sebaceous material, you have hair, you have teeth, you may have thyroid tissue, and when you have one element predominant, it's called a mesodermal teratoma. How will they present? They may be asymptomatic, but very often they present with acute abdominal pain. And when you have this could usually be a torsion. So an acute abdominal pain situation arising, a question comes in a young reproductive age group female with acute abdominal pain with an adnexal mass, not responding to analgesics, what should you think of? Think of torsion. What is the investigation of choice in torsion? It is an ultrasound plus Doppler. So you will find loss of blood flow or the whirlpool sign. Then you know that there is no flow going to this structure. What is a fibroma? Ovarian fibroma is a non-functioning mesenchymal tumor. It is solid grayish-white tumor, and it typically causes what is called the Meek syndrome. Meek syndrome is a fibroma plus ascites plus pleural effusion. Okay, so you have peritoneal irritation causing ascites and pleural effusion. This is not a malignant ascites. It's not a malignant effusion, but it is seen in a benign tumor called fibroma. This is called as Meek syndrome. What is pseudo-Meek syndrome? Pseudo-Meeks is when any other pelvic tumor, uterine or ovarian, any other tumor causing ascites, presenting with ascites plus pleural effusion is called as a pseudo-Meeks syndrome. Then you have the sex cord stromal tumors. Now, these could be benign or malignant. They could be the Sertoli Leydig cell tumors. These were earlier called as arenoblastomas, and they present as virilization. Okay, so you will have a girl presenting with hoarseness of voice or hirsutism or clitoromegaly, and they were also earlier called as arenoblastomas. Granulosa cell tumors and thecomas usually present with abnormal uterine bleeding patterns, say precocious puberty or postmenopausal bleeding or some other form of abnormal uterine bleeding. Now, it's very important to differentiate a malignant from a benign ovarian mass on the ultrasound, okay, and on other features, so that you know which patient, how to manage what patient, okay. So this is one of the, there are many ways you can do this. One of the commonly asked ones is the RMI. What is RMI? It is risk of malignancy index. This is calculated by an ultrasound score multiplied by the menopausal age score multiplied by the actual value of CA125. Okay. Now, ultrasound score is calculated by 5 parameters. So, 5 things we see in the ultrasound is if it's unilocular or multilocular. You see if it is bilateral or unilateral. You see if there's any ascites. You see if there's any solid areas. And you see if there is any metastasis. So if it is multilocular, it's given a score of 1. If it's bilateral, it's given a score of 1. If there's ascites, 1. Solid areas, 1. Metastasis, 1. So if you have nothing there, no abnormal ultrasound feature present, then you're given a score of 0. If you have 2 to 5 things present, then it is given a score of, before that, if you have one thing present, any 1 of 5 features present, it's given a score of 1. And if you have 2 to 5 things present, it's given a score of 3. So the possible scores are 0, 1 or 3. This is the ultrasound score. What is M? M is the menopausal score. So if she's pre-menopause, it's given a score of 1. If she's post-menopause, it's given a score of 3. And then you take the actual CA125 level. Say it's 100. So you multiply 100, say 100 value in a premenopausal lady with the ultrasound score of 1. So it's 100 times 1 times 1, it is 100. So if the score is less than 200, it is less likely to be malignant. Okay, so it is more likely to be benign. If the score is more than 200, it is more likely to be malignant. So this is one way we can determine the risk of malignancy in an ovarian mass. Apart from these benign ovarian masses, we also have an endometrioma or chocolate cyst, which I have told you about. We also can have in PID, tubo-ovarian abscess, which presents as, there will be typical features of PID, fever, lower abdominal pain, foul-smelling discharge, multiple sexual partners. All these would be given. Or maybe some intervention was done post-DNC, post-abortal. She's developed these signs and symptoms, and when you do a scan, you find a tubo-ovarian mass. Or you can have a para-ovarian cyst, so this is a tubo-ovarian mass. You can see pus is collected inside. This is also a tubo-ovarian mass, how it looks like. You can see the tubes are also involved, the ovaries are also involved. This is an endometrioma. The picture has gone tera, but this is how an endometriotic cyst or chocolate cyst will look like on ultrasound and on laparoscopy. This is an image showing a torsion. So this is ovarian torsion. You can see that the tube and the ovary have twisted on itself. Okay, and what do you do when you have such a situation? You do a laparoscopy you do a detorsion, you untwist the twisted ovary, and you can see that the ovary has become black in color because of the disruption of blood supply. So detort it, wait a bit, see if there is return of blood supply. Does the ovary become white again? If it is, then you just do a cystectomy. But if the blood supply still remains cut off, then if it still remains black, then you should do an ovariectomy, remove the entire ovary, because that ovary is now dead. Now coming to ovarian cancers. Now ovarian cancers, the classification is very simple. We have surface epithelial tumors where we've already discussed these under benign also. So you have serous cyst adenocarcinomas, mucinous cyst adenocarcinomas, Brenner's, which is most commonly benign, but you can have malignancy also, endometrioid cancer, and clear cell cancers. Then you have germ cell. In germ cell tumors, we've discussed the teratoma, the mature teratoma, which is dermoid, which is usually benign, but you have other things like dysgerminoma, yolk sac tumor, immature teratomas, or choriocarcinomas. And then you have the sex cord stromal tumors, where we've discussed these, but you can also have malignant variants of all the three types. Now, tumor markers are very important. Tumor markers, remember, they are asked in the exam very commonly. So, we start with CA125. This is a tumor marker for epithelial ovarian cancer, commonly serous cyst adenocarcinoma. That's why it's used as a marker for the RMI index also. Then we have CA199 and CEA. These are markers of mucinous cyst adenocarcinoma. But remember, again, they're not very specific. Even CA125 can be found to be raised in conditions like pregnancy, in conditions like PID, in conditions like genital tuberculosis, and even endometriosis. Okay. Then what else can there be? Then we can also have LDH. LDH is raised in dysgerminoma. Remember D and D. Okay. Then you have alpha fetoprotein, which is raised in yolk sac tumor. Then you have beta HCG, which is raised in non-gestational choriocarcinoma. And then you have inhibin A and B both, which is raised in granulosa cell tumors. Okay, so this is very important. The ovarian tumor markers, it comes repeatedly many times in the exam. Now, staging of ovarian cancer, again, it's something which is not very important, but I've still put it here for you to just have a go through, a look at it. Okay. So, stage 1, I won't again go into the details, just the top stages. Stage 1 is when it is confined to the ovaries. Stage 2 is when it involves one or both ovaries. So, fallopian tube is also written because ovarian tumor and fallopian tube cancer staging is the same. Okay. So, with pelvic extension becomes stage 2, and this is below the pelvic brim. If it has spread, it is stage 2. Stage 3 is when it has spread to the peritoneum outside the pelvis, or it has metastasized to the retroperitoneal lymph nodes. So, outside the pelvis, metastasis, or the lymph nodes, it is stage 3. And stage 4 is pleural effusion, and that means excluding peritoneal metastasis, all other metastasis like to the liver or to the lungs, that is all stage 4. So, stage 4A is pleural effusion, stage 4P is parenchymal metastasis and metastasis to extra abdominal organs, including lymph nodes. Okay, this becomes including lymph nodes outside, not the pelvic parietic, other lymph nodes outside the abdominal cavity, including inguinal lymph nodes. If the question comes inguinal lymph nodes in ovarian cancer, it straight away becomes stage 4B. Now, remember, ovarian cancer is the surgical staging, and this is what you should remember. This is what is important. In fact, ovarian cancer and endometrial cancer are surgically staged. So, what do we do when we have a suspected ovarian cancer or a proven ovarian cancer? We have to do surgery. What is the name of the surgery? We do what is called a staging laparotomy. Okay, or what is called a debulking surgery. That means you have to do surgery and remove the uterus, remove the ovaries, remove the fallopian tube. So, you're going to do a THBSO. Along with that, you're going to go in a uniform manner, usually in a clockwise or anti-clockwise direction, and you remove all possible tumor lesions wherever it's spread. It could be the omentum, you do an infracolic omentectomy. It could be to the peritoneum, you take out wherever you see the visible macroscopic metastasis, you keep removing it. and keep taking biopsies from everywhere, including the lymph nodes. So that's called a staging laparotomy. And debulking means when less than 1 centimeter of tumor bulk is left behind. This is called an optimal debulking. That means you have optimally done the surgery. If you have removed all tissue with less than 1 centimeters being left behind. So staging laparotomy or debulking surgery followed by chemotherapy, which is usually a platinum based chemotherapy, usually given 6 cycles 3 weeks apart. So platinum based means we usually give cisplatin or carboplatin plus paclitaxel. This is the usual treatment option for a serous cyst adenocarcinoma, and this is very commonly asked in the exam. So staging laparotomy, where you try to do an optimal debulking followed by 6 cycles of platinum based chemotherapy, is what is done in ovarian cancer. Now the chemotherapy is paclitaxel plus cisplatin or carboplatin. So 6 cycles are given every 3 weeks. And this is important, especially for I&I point of view. There's something called as platinum sensitivity. How do we know if this patient is sensitive to the platinum based chemotherapy? So look at this picture. This picture is very self-explanatory actually. So you have a patient who's undergone surgery, and after surgery we start her on chemotherapy. So you can see 6 cycles, 1, 2, 3, 4, 5, 6. Okay, and then we see what happens. Now if she has a recurrence while on the chemotherapy, say you've done surgery and while she's on a 3rd cycle of chemotherapy, she develops ascites again, you do a tapping and you find that malignant cells have reappeared. So she has had a recurrence while on chemotherapy. That means she's refractory. She has not responded to chemotherapy at all. So you're going to change her chemotherapy regime. There's a 0% chance she will respond to the same chemotherapy. Okay. Now, if you have finished your 6 cycles of chemotherapy and within 6 months she has a recurrence, 6 months of finishing the chemotherapy, she has a recurrence. It is called as resistant. So she is platinum resistant. And again, giving the same regime, she is going to be less than 10% chance she is going to respond. So better to give a different regime. This is called as platinum resistance if the recurrence happens within 6 months of giving the drug. Now, if the recurrence happens between 6 to 12 months, then she is partially sensitive. And if the recurrence happens after 1 year, after 12 months of receiving chemo, then she is sensitive. Then there's a good chance she will respond again and you should give the platinum-based chemotherapy again. Okay, so while on chemotherapy refractory, within 6 months resistant, 6 to 12 months partially sensitive, and after 12 months she is platinum sensitive. That's an important thing. Okay, now there's something called as neoadjuvant chemotherapy. What is this? Women who have advanced ovarian cancer, okay, which appears unresectable. That means which appears you will not be able to achieve a good surgery because everything is too much disease, or she is not fit for surgery, poor general condition. In these two situations, you can give her what is called as neoadjuvant chemotherapy. That means give 3 cycles of chemotherapy, okay, and then operate, then do surgery, and then follow up with 3 more cycles of chemotherapy. So these initial 3 cycles are going to melt the tumor. They're going to reduce the tumor bulk and make her more operable, or they will improve her general condition, and then you can operate after 3 cycles of chemotherapy. Now, a little bit words on the other malignant tumors. Dysgerminoma is the most common malignant ovarian tumor in pregnancy. What is the most common benign tumor in pregnancy? Most common benign tumor, ovarian tumor in pregnancy is a teratoma, a dermoid. Okay, and the most common malignant is a dysgerminoma. The tumor, and it's common in dysgenetic gonads. Remember, we talked about Swyer syndrome, androgen insensitivity. In these, dysgerminomas are common. The tumor marker is LDH. Remember, D for D, dysgerminoma, LDH. What do you see in the dysgerminoma? You see these cells. These are called the fried egg appearance on histopathology. What is this? This is a yolk sac tumor. What are you seeing here? You're seeing a Schiller-Duval body, commonly asked question. In granulosa cell tumors, you see the coffee bean nucleus, where we also saw this in the Brenner tumor. And you also see these bodies. These are called the Call-Exner cells. So that ends ovarian cancer. So remember, cervical cancer most important if you're reading in that order, then endometrial hyperplasia and cancer, and ovarian cancer. These are the three most important gynae cancers that you should go through before the exam. Now we start with instruments in gynecology, which are occasionally asked in the exam. So you should be able to identify these instruments based, and they usually ask as image-based questions. What is this? This is a Cusco's self-retaining speculum. Remember that the biggest advantage is it is self-retaining. That means once you place it, your hands are free. So you can do procedures with your hands. You don't need an assistant. But because the space is limited, the disadvantage is it is space limiting. Only one more instrument you can put through this once you have put this inside. So you can't see the vaginal walls completely. So it obscures the vaginal walls. Okay, and you can only put one more instrument. So you can do a limited number of things with this. Like you can visualize the cervix. You can take a pap smear. You can remove a copper T, okay, or an intrauterine device, and you can probably do a colposcopy when you're like same visualizing the cervix or doing a colposcopy. These are what you can do. You can't do much more than this. So it's usually an instrument used in the OPD. What is this? This is another type of speculum. This is a Sims speculum, okay, and you can see it has valves on both the ends, okay, and it has a central groove in the middle. The groove is so that secretions can drain out. If she's bleeding or if she's leaking, the secretions can drain out through that. This is the disadvantage of this is that the space, although the space is more, the disadvantage is you need assistance. You need another person because this is going to retract the posterior vaginal wall. And then using this instrument, what is this? This is an anterior vaginal wall retracted. Using this instrument, you lift the anterior vaginal wall and then only you can see the cervix. So you need both instruments together. So you need assistance. And once you use both your instruments, your hands are again occupied. But the advantage is you have much more space. So space is a lot. So you can do many procedures like putting in an intrauterine device or doing a dilatation and curettage or doing a vaginal hysterectomy. Any vaginal procedure you can do using the Sims speculum. Now, what is this? These are Hagar's dilators. Hagar's dilators are mechanical cervical dilators. So, whenever you want dilatation of the cervix, you use the Hagar's dilator. They are metal dilators which start with a diameter of 1 millimeter, 2 millimeter, 3, 4, 5, 6, and so on and so forth. Usually, the largest is 12 millimeter or 14 millimeter. Okay. And since dilatation is painful, it's usually done under a local anesthesia or a general anesthesia or some sort of anesthesia because dilatation, especially mechanical dilatation, is going to be painful. So it's done before DNCs or if you're doing a hysteroscopy using a larger size scope, you may have to dilate the cervix beforehand. What is this? This is a valsalum. Valsalum is a long instrument curved slightly with a lock with teeth at the end. If you look at the end, it has teeth like this. This is used to catch hold of the cervix. Usually the anterior lip we hold. Okay, like if you're doing a dilatation and curettage or taking a biopsy, or putting in an intrauterine device, you want to hold the cervical lip. And the valsalum is a good instrument. You can also use a tenaculum. A tenaculum has more grip. You can see it has a single tooth, okay, on the end. This is a tenaculum. It's very similar to a valsalum in terms of function. What is this? We've seen this in the video earlier. This is a curette. It's a uterine curette. It has two ends, a blunt end and a sharp end. The blunt end is used in a pregnant uterus, like if you're doing an MTP and you want to confirm that all the products have come out, you can use the blunt end of the curette. And in pregnant uterus, we don't use the sharp end because of the risk of perforation. A pregnant uterus is much more soft. The sharp end is used in gynae uteruses, that means non-pregnant uteruses. Okay, if you want to do a dilatation and curettage, primarily it's used when you want to take a biopsy from the endometrium, that is doing a DNC. What is this? This is an aspirator. It's an endometrial sampler or an aspirator, again used to take an office, that is an OPD procedure, office endometrial biopsy. The biggest advantage of this over a DNC is it's so thin, this cannula, Okay, it doesn't require cervical dilatation. So that pain of dilatation the patient is not having. Okay. What is this? We've discussed this in obstetric instruments. This is an MVA syringe, and these color coded are Carman's cannulas. Okay, and they are used for surgical MTP before 12 weeks of pregnancy. Okay, so what is done? That has two valves here. It's double valve. It has a 60 cc cannula. So when you pull the plunger, you create a vacuum. Okay, and then you attach the Carman's cannula, put it inside the uterus through the cervix, attach this apparatus, and unlock the locks. Press the lock. So vacuum gets released, and the products of the uterus come out and get suctioned inside. It doesn't require electricity. It's manual apparatus. Those are the biggest advantages. It is very useful in low resource settings. What is this? We've discussed this. This is to take a pap smear. You have the air spatula. You can see it has two ends. This is the end we use on the ectocervix. Okay, it also has a blunt end which is used, and this can be asked. This is used when you're taking a vault smear. What is a vault smear? In a patient who has undergone hysterectomy and you want to sample the vaginal vault. Say she had hysterectomy for stage 1A1 cervical cancer. When she comes for checkups, you want to take vault smear to look for recurrence. Now, when the vault is there, you don't need this beveled edge. You just need a plain edge, and you can use this side to take a vault smear. This is a cytobroom, and this is used to take a sample for HPV DNA. This is a punch biopsy forceps. If you have a frank growth on the cervix, you're going to use a punch biopsy forceps. This is a colposcopy. So we've already gone through all these. This is a colposcope. It visualizes the cervix under magnification. What is this? This is a Babcock's forceps. Not very clear. The end is atraumatic. That's important. It is used to hold delicate structures, and in gynecology we use it to hold the fallopian tube for either fallopian tube ligation or fallopian tube recanalization, or when you're doing a salpingectomy, say in an ectopic pregnancy, you will hold the fallopian tube using a Babcock's forceps. What is this? This is an Alice forceps. We've discussed this in obstetric instruments also. It is a traumatic. It has teeth at the end, so it's used to hold tough structures. Commonly in gynae, we'll use it during surgery. We'll use it to hold the rectus sheath. Okay, it can even be used to hold the cervix when you're doing a vaginal hysterectomy. What is this? We've discussed this. This is a Bonnie's myoma screw used in myomectomy surgeries. This is a Bonnie's myomectomy clamp, which is applied at the lower part of the uterus. It occludes the uterine arteries, reduces the blood supply to the uterus. This is a Bonnie's myomectomy clamp. What is this? This is an HSG cannula called a Leach-Wilkinson cannula, which is used in HSG. Not only HSG, it's used in laparoscopic chromotubations and saline infusion sonographies. It is basically used to inject the dye through this end. This part goes inside the cervix, and the dye will reach the uterus and the tubes through this instrument. Now coming to laparoscopic instruments. This is the laparoscopic tower, okay, which has the monitor on top. Okay, it has the camera apparatus here. It has the light source here. It has the insufflator, the gas. Carbon dioxide is the gas we use in laparoscopy. It is the insufflator which supplies the gas to the abdomen. This is a laparoscope. This instrument is actually through which we look inside the abdomen. The camera is attached here. The light source is attached here. And this part goes inside the trocar, inside the abdomen. These are different laparoscopic instruments. You have graspers, scissors. Okay, this is an electrocautery machine through which we have two types of cautery. We have a monopolar cautery and we have a bipolar cautery. Another energy source, if you want to coagulate tissue, is this. This is an ultrasonic device which produces heat energy by ultrasonic waves. This particular apparatus is called a harmonic device. Now, when you're doing a laparoscopy, the first thing is you create pneumoperitoneum. How do you create pneumoperitoneum? Using this instrument. This is a Veress needle, okay? And after creating, so once you put the Verey's needle inside, once it's inside the peritoneal cavity, you attach the carbon dioxide tubing to it, which through the insufflator will insufflate the abdomen. Now, once the abdomen is insufflated with carbon dioxide, we then put the trocars. So you have the primary trocar or primary port through which the laparoscope will go in, and then you have the accessory or the secondary trocars through which the instruments will go inside. Now, this diagram is important, and I'm sure you've read this in surgery, is how do you put in abdominal surgery, in gynae surgeries especially, where do you insert the Verey's needle? Now, a common place we insert the Verey's needle is just below the umbilicus, subumbilically. But you can also insert it here, that is supraumbilically. You can also insert it in a point much higher called the Li Huang point. This is not commonly used for gynae laparoscopic surgeries. If the patient has a history or you're expecting adhesions inside, then the safest point, and this comes as a question, is the Palmer's point. The Palmer's point is a point 3 centimeter beyond the subcostal margin, okay, 3 centimeter below the subcostal margin. At the mid-clavicular line. So this is a safe point. It's a safe entry point. So remember, Palmer's point is the safe entry point. Okay. Now, in gynae, apart from laparoscopy, we also very commonly use a hysteroscopy. Now, hysteroscopy is an instrument which is used to look inside the uterus. Okay. And you can use it for diagnostic purposes. Okay. For example, if a woman comes with infertility, okay, or if you're suspecting a Mullerian anomaly like a septate uterus, or if you're suspecting Asherman syndrome, okay, or if you're suspecting abnormal uterine bleeding, you don't know the cause, maybe there's a polyp you're suspecting, so diagnostic reasons. And then therapeutic. Therapeutic means you want to treat her. That means maybe you want to do a polypectomy, there's an endometrial polyp inside, or there is a submucosal fibroid, so myomectomy, or you want to do a septoplasty for a septum, or you want to do an adhesiolysis for Asherman syndrome, or you want to remove an intrauterine device whose thread has broken off and you're unable to remove it in the OPD with a Shirodkar's hook. So these are common indications, or in diagnosis apart from AUB. Here I'll also add postmenopausal bleeding and you want to take a biopsy. So these are the indications for doing a hysteroscopy. Now remember, like in laparoscopy, we distend the abdomen, the peritoneal cavity with carbon dioxide. In hysteroscopy, we distend the uterus. So look inside the uterus, you have to distend it. We can either use carbon dioxide, but this is not commonly used at all. Okay. So the other thing we can use is fluid media. Fluid media, earlier high viscosity liquids were used, but again not commonly used. What we commonly use now are the low viscosity media. And in this, normal saline is very commonly used, which is a conductive fluid. Okay. And it is safer, especially if you are using it for longer durations. Also, it is safer when you're using bipolar cautery. Non-conductive is glycine, mannitol, sorbitol. These are used when you are using monopolar instruments, monopolar cautery. You will use a non-conductive solution. Also remember, there is something called a fluid deficit. So when you're doing a hysteroscopy, what is done is the hysteroscope is inserted inside the uterus. Okay, the fluid is switched on. Now there's something called a fluid deficit, and it's very important to understand this concept. What is a fluid deficit? Fluid deficit means you are putting fluid inside the instrument. Okay, this is the instrument, it's gone inside the uterus. Okay, and it distends the uterus. Okay, now this fluid which goes inside should also come outside. So there's an output, there's an outflow tract, there's an inflow tract where it's going inside, and there's an outflow tract where it comes outside. Okay, so normally what happens is jitna andar ja raha hai, the input should be equal to the output, because the uterus is a closed structure. Little bit will go through the fallopian tubes, okay, little bit, but most of it should come out. That means input is equal to output, but that's not the case. The output will always be a little bit lesser, because apart from going through the fallopian tubes, some food will also get absorbed into the, it will go into the vasculature of the patient. Okay, so it will get absorbed. Now that absorption is what we need to find out. So that is called the fluid deficit. How much fluid has disappeared inside the patient's body. This is calculated by the input minus the output. Okay, now this fluid deficit, if it's very, very large, now if we're using normal saline in a low risk patient, we can let the fluid deficit go up to 2.5 liters also. Okay, because it's a electrolyte balanced solution, we're not that worried. Even if it enters the circulation of the patient, it will not cause too much problem. But once it crosses 2 to 2.5 liters, this patient can have electrolyte imbalance. She can have even develop pulmonary edema and finally cardiac arrest. So it's called as water intoxication syndrome. So this is what happens if too much fluid gets absorbed into the body. And this if you're using, say, glycine, okay, the non-conductive material, fluid media, then the upper limit is taken as 1 liter. So you should not be giving more. The fluid deficit which is being calculated by the people in the operation theater, it should not go more than 1 liter. If it goes more than 1 liter, then the risks of this become higher. So you're safer using normal saline, where the fluid deficit can allow to go higher. Okay, but if you're using glycine or sorbitol or mannitol, then you can, the cutoff, the fluid deficit should be not be more than 1 liter. If it's crossing this much, then you should stop the procedure. Okay, ask the anesthetist if the patient is fine, wait for some time, or continue the procedure at a later